Good afternoon.
Good afternoon, Madam Chair.
I love it. Today is Wednesday, February 18th. You are in the Senate Finance Committee. Thank you for being here. We will hear 9 bills today. It's an easy day. We're, almost on vacation. The sponsors of the bill have as much time as they need to present the bill. Other witnesses get 2 minutes. Please listen for the buzzer. When the buzzer goes off, please finish your sentence. Don't make me gavel you. We were here at 8:45 last night, so little PTSD. But thank you all for being here. I'm going to read the order of the bills. We're going to start with Senator McCray, Senate Bill 461. Senator McCray, you can come to the table if you like, and bring your panel if you have one. Then 445, 428, 473, 495, 469, 505, 416, and 417. So we will start the hearing with Senator McCray.
Thank you, Madam Chair and members of the committee. I come to you in reference to Senate Bill 461. For the record, Corey McCray, represent 45th District, East and Northeast Baltimore. Madam Chair, this bill is very simple. It was requested by the department to make sure that we align when you come for BGE, or I'd say BGE, but heat services, that SNAP is aligned with it. It pulls us in alignment with our federal law, so making sure that everything is moving in one direction, and there is no opposition, and I will not belabor you anymore. I just ask for a favorable report. Very easy bill.
Thank you. Does the committee have any questions for this very easy bill? Usually that's the kiss of death, Senator McCray. So thank you for your testimony.
Yes, ma'am.
Next, we're going to go to Bill 445, Employment Standards, Firefighters, Payment of Wages and Payroll, and Senator Kramer is going to present. You had a very good example with Senator McCray.
And it's a shame it's going to go south from here, Madam Chair.
And then we'll have Jeff Buttle from the Professional Firefighters and Joshua Fannin, Baltimore Firefighters. Thank you.
Good afternoon, Madam Chair, members of the committee. Ben Kramer here to introduce Senate Bill 445, which is going to sound kind of familiar, as I know you all are very tuned in to every bill I introduce. And this one was introduced last year. And hopefully this is the year we're going to get it across the finish line, Madam Chair. Senate 445 is a straightforward fairness bill. It provides that governmental units employing firefighters must pay overtime for hours worked in excess of 42 hours in a work week. That's all the bill does. Today, under the Maryland wage and hour law, virtually every other employer in our entire state must pay overtime after 40 hours in a work week. The same standard applies under the Federal Fair Labor Standards Act as well. In nearly every profession and industry, overtime protections begin at 40 hours. Yet firefighters who routinely work extended shifts, nights, weekends, and holidays are carved out and treated differently. The vast majority of counties and municipalities already recognize that paying overtime at the 42-hour standard is both fair and necessary to recruit and retain qualified public safety professionals. This bill simply ensures consistency and equity across the state. Let me be clear about what the bill does not do. It is prospective only, and it does not disturb or impair existing collective bargaining agreements. It does not retroactively change contracts. It simply establishes a forward-looking, uniform uniform baseline standard. Firefighters put their lives on the line for our communities. They respond to fires, medical emergencies, hazardous materials incidents, natural disasters, and public safety crises at all hours. They work 24-hour shifts. They miss holidays, and they miss family milestones. And when they exceed a full work week, they deserve the same basic labor protections afforded to every other worker in Maryland. This is fundamentally an issue of fairness and equity. Hardworking women and men who protect our communities should not be afforded fewer wage protections than employees in the private sector or other public employees. Finally, where local jurisdictions are unwilling, including my Montgomery County, which is an embarrassment, unwilling to address overtime through collective bargaining, the state has both the authority and the responsibility. Colleagues, I'm going to repeat those words. It is our job, representing the state, to take the responsibility because we have the authority to ensure minimum labor standards are upheld. We do this in countless other areas of employment law. Establishing a uniform overtime threshold is well within the state's role in setting baseline worker protections. Senate Bill 445 simply provides that firefighters deserve the same respect and dignity under our wage laws as everyone else. For equity, for consistency, and for the hardworking public servants who keep Maryland safe, I respectfully ask for a favorable report on Senate Bill 445, and I will quickly note that despite my love for our friends from ACO, I see Carrington back there, in their letter of opposition, which is streamlined considerably over last year's, and I had a field day over that one. This year, though, it includes the following. Counties across Maryland and nationwide are already facing serious challenges in recruiting both career and volunteer firefighters. Madam Chair, members of the committee, I believe that statement makes the case for why we need to pass this bill, because we are struggling to recruit and retain. Well, I would posit that a big part of that is that in Montgomery County, in Frederick County, in Howard County, and in Baltimore City, we are not honoring overtime labor standards that every other employee in the state is provided. With that, thank you, Madam Chair, and I'm happy to turn it over to this outstanding panel.
Thank you, Senator. You did well today.
Thank you, ma'am.
Sure. Good afternoon, Madam Chair. Jeff Buttle, President of the Professional Firefighters of Maryland. We represent over 10,000 active and retired firefighters and emergency medical services workers across the state of Maryland. I just wanted to address, this bill is really simple. It's not a complicated bill. It simply would establish one uniform standard that would be applied statewide for when firefighters start getting paid overtime. There's a lot of information out there about having to hire more firefighters, having to add additional staff, having to create new shifts. This bill doesn't require any of that. It simply establishes the threshold uniform statewide for when it is that firefighters begin getting paid overtime. We were curious in the off session what the general public thought of this issue, because it's been around for a couple years now. And we conducted a poll of 808 registered voters across the state of Maryland who indicated they were likely to vote in the general election this fall. The poll had a margin of error plus or minus 3.5%. And the question we asked was, currently, firefighters in Maryland work 42 to 48 hours per week before overtime begins. Should all firefighters across the state get paid overtime after 42 hours per week, creating one uniform standard instead of varying department rules? Yes or no? 81.8% responded yes. Madam Chair, look forward to working with the committee on this very important bill. Ask for a favorable report, and thank you for the time today.
Joshua?
Good afternoon, Madam Chair, members of the committee. My name is Josh Fannin. I'm the president of IEFF Local 964, Baltimore Fire Officers. I'm testifying today in strong support of this bill to ensure firefighters receive overtime pay for hours worked beyond the 42-hour weekly average. This is the third time in as many years that I've been before this committee with a similar bill. Last year, the House of Delegates passed it with overwhelming bipartisan support, 134-1, a near unanimous vote, recognizing the clear need for fairness in how we compensate our first responders. I wanted to look at some professions that get overtime after just 40 hours. Construction workers on job sites, factory workers on the lines, retail staff serving customers, office administrators managing paperwork, delivery drivers covering routes, and hospitality workers in restaurants and hotels. Those roles are vital, but rarely match the life-risking intensity firefighters face daily. Even closer to home in Baltimore City, police officers receive overtime for hours worked over 40 hours per week. Paramedics and EMTs in the Baltimore City Fire Department also receive overtime over 40 hours per week. Why should firefighters who face the same medical dangers on calls as the paramedics and EMTs they work alongside every day, and who routinely support police officers, be held to a higher, less equitable threshold? In jurisdictions like Baltimore, employers have had every opportunity to do the right thing through collective bargaining. Instead, we've seen efforts to increase work hours without corresponding protections. This statewide standard levels the playing field, promotes equity, and helps retain the experienced firefighters our communities rely on. This is about basic fairness for those who protect us every day. I respectfully urge a favorable report. Thank you for your time and consideration.
Thank you. I have a question for, I guess, Mr. Buttle. If you work your scheduled hours, is it like 168 hours a month?
Yeah, that's the average over the cycle.
So it's only if you have to stay over or get called in extra that really you go into overtime, correct?
Yeah, yes, and the numbers are in the bill. It's the number you referenced was over a period of time, but it averages, this bill would make it average over 42 hours per week.
Well, there's a lot in the fiscal note, but not any real numbers, just,
Yeah.
the millions of dollars.
Yeah, I was referring to the text of the actual bill.
But thank you. I just didn't know if this really applies to when you're held over or your regular work schedule. So it's
Oh,
just,
it's when you're working more than your regular work schedule.
thank you. Thank you for that. Do I have any other questions for this panel? Thank you very much, Senator Kramer, and thank you, Jeff and Joshua. We're going to bring up the two unfavorables, John Peterson from Frederick County and Carrington Anderson Mako.
Are you ready? Thank you. Chair Vidal, members of the committee, thank you for the opportunity to provide testimony on Senate Bill 445. For the record, I'm John Peterson, Chief Administrative Officer for Frederick County Government. I'm here on behalf of County Executive Fitzwater in opposition to SB 445. County governments and fire departments determine schedules on the basis of staff requirements and operational needs. In our recent bargaining in Frederick County, we have not had a proposal for a 24 72-hour schedule or for overtime after 42 hours of work. That is not to say we won't get a proposal for a 24 72-hour schedule in the future, but it should come at the bargaining table where it belongs. Moving to a 24 72-hour schedule and adding a fourth shift would take years and cost upwards of $20 million annually. One of the recommendations in the after-action report following the line of duty death of Battalion Chief Laird was to staff all career fire engines with 4 firefighters. We have worked hard to improve our service delivery to include this full recommended staffing level. Frederick County has a proud combination fire service of volunteer and career firefighters. We do our best to respond to volunteer companies requesting career officers to staff stations. This bill would limit our ability to provide full recommended staffing and will take away opportunities to augment our volunteer companies, causing safety issues for our firefighters and residents. Local governments have limited resources and competing interests. Our school systems are asking for increased funding as they work to implement the pillars of the blueprint. There's no question that counties are being asked to do more to support LEAs. County Executive Fitzwater has worked with and continues to work with our local school board and school superintendent to find ways to fund the growing needs of our school system. This bill is billions of dollars that we will not be able to provide our school systems. In summary, this bill interferes with long-established collective bargaining between local governments and the IAFF. It would be a huge cost burden to Frederick County and other similar jurisdictions. It would limit our ability to provide recommended staffing levels and greater service to our residents, and would take dollars away from other competing priorities, most importantly, our school system. Please find unfavorable about this bill and allow these items to continue to be part of collective bargaining at the negotiating table where they belong. Thank you for the opportunity to speak with you today.
Thank you. Carrington?
Thank you, Madam Chair and members of the committee. My name is Carrington Anderson, here on behalf of the Maryland Association of Counties in respectful opposition to Senate Bill 445. You have my written testimony, so I will be brief. Counties' concerns with this bill is that this does undermine local collective bargaining. I will say it's not accurate to say that all counties across the board, besides a few, are already doing this. There's only 7 jurisdictions that employ paid firefighters, and maybe 3 of them are doing this, so we're looking at really only 7 that have paid firefighters that this would apply to. So this undermines local collective bargaining authority. We think that this is best done at the local level. Additionally, there's really 2 options for counties if this bill passes. They either pay those overtime wages, which 24-hour schedules are very common. It's common to have a 24 on, 48 off, 24 back on, and that alone would require overtime in this bill. There's a reason that there's a partial exemption here for firefighters. That's that federal exemption. It's because of these unique schedules that takes a lot into account. This is different from an average 40-hour job. This doesn't fit into a normal 40-hour week. So counties either pay those overtime wages every week, or counties would have to hire a number of firefighters to change that schedule, which is not possible because of all of the recruitment and retention issues. So unfortunately, I don't think this bill is going to move the needle on recruitment and retention. So for these reasons, we'd respectfully request an unfavorable report. Thank you.
Thank you. Senator Washington?
Thank you, Madam Chair. Carrington, thank you for both for being here. You mentioned the 5 counties or 7 counties that this would apply to, but 5 of them, 2 of them already do it, but 5 of them are this would apply to. Is that correct? I was trying to find the answer in your testimony, but I don't see it in here.
Thank you for the question, Senator. So most counties have volunteer firefighters, so this bill would be for paid firefighters. Correct. There's about 7 jurisdictions that do have paid firefighters. I think 3 of them already have this schedule, and they have this schedule because they locally negotiated it. They took into account different offsets for benefits, so they figured out how to make that work locally. If this goes into effect, then those other jurisdictions that don't do that, there's no negotiating power because it's a statewide mandate.
I'm guessing Frederick is one of them. Who are the others that are on that list that have not
Frederick,
negotiated this?
Howard, Baltimore City, Frederick, Howard, Baltimore, and Montgomery County.
So just, yeah, I think you could look at the fiscal note. You're going to see some of the counties that have submitted stuff. The jurisdictions who don't do this, their information is in the fiscal note. And I will say, I know that there's no numbers specifically mentioned. I know those jurisdictions did include those numbers, so I'm not sure why just millions is referenced, because there are specific numbers, and would be happy to get that to the
The reason I
committee
asked that question is if it's only seven jurisdictions that this applies to, for MACO, were those 7 jurisdictions, did they make a vote saying no to this? Those 4 that did not did not agree to it, like Frederick? Did they take a vote in Mako and said they did not support this legislation?
Senator, thank you for the question. I will say, first of all, Mako has an internal policy that we do not share the votes that happen in our legislative committee. I'm here on behalf of Mako, but I will say local collective bargaining is an important for counties, and anytime that's going to be attacked, we're going to have concerns with that. So I'm sorry I can't share which counties voted for what bill.
Got it. I can see from the testimony who's on that list, so thank you.
Thank you.
Thank you, Senator. So I have a question. I'll let the sponsor go first. No, okay. Thank you. So you mentioned collective bargaining, that this could be worked out in collective bargaining. So this bill's been in front of us 4 years, maybe? Third year, okay. And so we hear the same thing every year from our firefighters. They've had collective bargaining in this period of time. So if it's important to the firefighters, why isn't it being addressed in collective bargaining? And are these counties that do not have binding arbitration?
So,
Do you want to start?
yeah, so I've worked in a couple of jurisdictions where this issue has come up. So we negotiated when I was in Howard County, that did come to the table, and we, went through the trade-offs and what it would take, and ultimately, there was not, from the administration side, there wasn't enough enough savings to accomplish that schedule. And the union chose not to take that to arbitration, which they did have the right to take it to binding arbitration, but they didn't. In Frederick County, this has not come up at the table. We have every belief that it will come up in the future, but it has not been a subject for negotiation in Frederick County. So the firefighters have not brought that to the table.
So my county, Anne Arundel, has the 42-hour then overtime, and we also have binding arbitration. And we learned that it was less expensive to hire additional firefighters than it is to pay overtime. Do you think that's true in most counties?
Yeah, you're going to have to make that trade-off. You're going to have to figure out where that breaking point is, where you're paying overtime versus hiring on another shift.
Yeah, but I do think that it's more productive. It's better for the firefighters if you have enough firefighters than the counties. It's a physical impact for them to be paying overtime when they should just be hiring additional firefighters.
Madam Chair, can I add something to that, please?
Yes, please.
So agree with what you're saying there, and I think many jurisdictions would look into hiring more firefighters. I think there's some challenges with that. One of those is the cadet classes. Those, I think, are around 9 months, so it's not like you could instantly get more firefighters. You have to wait for that timing of training, and then there are the recruitment and retention problems.
Carrington, thank you for that, and I agree with you most of the time, but it's been 3 years. There's been a lot of 9-month classes in 3 years. Thank you. Senator Kramer?
Thank you, Madam Chair, and I was just going to follow up on that. If we had passed this 3 years ago, those classes would have been graduated and in uniform and on the JOB right now, but here we are just the same. And, I appreciate this notion that, well, let's take it up in bargaining. Well, I don't know what has or has not happened in Frederick. I know what has happened in Montgomery County, and my county executive has simply said, it's not going to be part of the conversation. If it's not going to be part of the conversation, then you can't negotiate it in collective bargaining. That's when it's appropriate for this body to step in and say, okay, if you don't want to do the right thing, the state is going to have to intervene. Now, thank you for being here, Mr. Peterson. Just a couple of quick questions. I note that in 2024, the opposition to this bill that was submitted to this committee, and actually, I take a look, I see it's over your signature, indicated that were this bill to have passed just in March of 2024, Frederick County would have needed to hire 94 additional employees at various ranks. I know just this short time later this year, the letter of opposition over your signature, sir, indicates that suddenly now it would be 150 positions, new positions. So we've gone up to 150 from the 94. Do you think it might be wise to quickly pass the bill this year? Because if you come in next year, I'm speculating it may be that you have 200 positions to fill. So why don't we do it right now and cut the losses that seem to be increasing dramatically with each passing year that this bill has not passed? And I also note that my understanding is Frederick has 615 career firefighters. Your value of an additional 150 is approximately a 21.74% increase using my meager math skills. So hopefully that's correct, which means that either you all are working your existing firefighters like rented mules and taking full advantage of the failure to provide them what they are due in their overtime wages, or the math here just doesn't add up. So I think that the written testimony is somewhat alarming and disconcerting. And I would also just now, do you all pay at 48 hours overtime? That's where Montgomery County is. When
48.
do you all pay?
48.
All right. So right now, firefighters that go into hours 43 to 46 are getting paid their regular wages, are they not?
Correct. They're negotiated wages.
So the difference really is just that overtime in that tiny little window right now that is meaningful to them, but you're already paying them their regular wages, yet you indicate that you will have to hire 150 people if you're paying them what they are due in that little window, just the difference between their regular wage and their overtime?
So respectfully, Senator, we are paying them what they're due and what they've negotiated for their salary. And we negotiate those salaries looking at other jurisdictions. So if another jurisdiction is working a 24, 72-hour schedule versus what our firefighters are working on a 24, 48, we use that as a comparison as do they. And they negotiate those wages based on that schedule. So those wages have already been negotiated in a collective bargaining environment, in a fair collective bargaining environment where they have the backstop of binding arbitration in the event that those wages were seen as not competitive or not fair. So we are paying fair wages. We are paying good wages to our firefighters. This bill would make it a mandate outside of collective bargaining on our county to pay an additional rate. So it would be bringing another partner to the bargaining table that, quite frankly, the IFF doesn't need. They're very good at negotiating. They have very strong negotiating power, and they do not need the state to negotiate for them.
And would you concede that every other employee in this state, whether it's private sector or public sector, is eligible for overtime at 40 hours?
No, police officers are also subject to the 270, the FLSA regulation that allows for overtime at a greater rate.
So you're saying, can you identify a single police department in the state? Because I'm curious, and I'd like to do a little follow-up on this, where the officers are in fact not getting overtime as I asked?
Over 40?
Or 42 if that's the same standard that they work for.
Yeah,
the firefighters.
a lot of police schedules are at 42 hours, and they're getting overtime after 42.
So you can't identify any departments that are not paying overtime at 42?
No.
Okay. Okay. I assumed as much. Thank you. Thank you, Madam Chair.
Thank you, Senator. I have no other questions for this panel. Thank you for your testimony.
Thank you.
That ends the hearing on Senate Bill 445. We'll now go to Senator Augustine, Senate Bill 428, Maryland Medical Assistance Program and Health Insurance. And Senator, I'm sure you want to bring up your panel, Dan Martin, Laura Willing, Kevin Roy, Kerry Guthrie, and Michael Gray.
Good afternoon, Madam Chair and committee. Senator Malcolm Augustine here on behalf of Senate Bill 428, which prohibits Medicaid and commercial carriers from imposing a copay, coinsurance, or deductible for behavioral health services provided via the collaborative care model. This committee is very familiar with the collaborative care model, and it's a validated patient-centered, evidence-based approach to integrating physical and behavioral health care in primary care settings. The model has been validated in over 90 randomized controlled trials and showed to improve health outcomes and reduce costs. According to a 2024 report from the MHCC, Maryland would need to double the current behavioral health workforce by 2028 to keep pace with the demand for care. The collaborative care model is an important strategy to address Maryland's behavioral health workforce crisis, especially in rural areas. It expands the reach of the existing workforce, allowing providers to treat up to 8 times the number of patients they can in traditional one-to-one settings. The collaborative care model was identified in that report, the workforce report, as a key strategy for addressing the state's workforce challenges long-term. Increasing the use of this model across Maryland is vital, but we are hearing from state partners that data show a drop-off in the model's billing after a patient's first visit, which totally defeats the benefit of the model. The decline in billing after the initial appointment is being attributed to a reluctance among patients to pay additional out-of-pocket costs for important follow-up visits. Senate Bill 428 would eliminate those out-of-pocket costs, which is a strategy that is key recommendation and is timely, given the new report on the collaborative care model that came out last week. And I will share with you all as a committee that I've worked on this with others across the country, particularly places like North Carolina that have had really better uptake on the value of this model. It is a best practice model across the country. We know we have this behavioral health crisis and that we have to really work to do everything we can to still do it, and getting people into care in the location where they are meeting them, which is the primary care. That is how this collaborative care model works. And this committee has heard me come in here. I'm very supportive of this, as you all know. But what I want to say is that you all have also heard me come into here talking about having a behavioral health well visit. And oftentimes what you've heard from the insurance carriers is whoa, 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 whoa. Don't do an individual behavioral health well visit. Why? Because we have the collaborative care model. We have the collaborative care model, and we want to make sure that we emphasize the collaborative care model. So I'm here in support of that, and in support to say that let's make that a higher uptake on that by virtue of removing that barrier, that cost share barrier that is there. Colleagues, we've done this in other areas that we find that are important, particularly around prevention for cancer screening, where we've removed that copay because we know that removing that barrier will get us a better uptake and a better outcome. There is a letter that came in from the league in opposition, and there are just a few things in there that I just want to highlight. One is that there's an indication in here that they acknowledge the fact that they are supportive of this model. Right? I mean, this is the working model, and that this is something that we agree to. But then they ask for additional study from the Maryland Healthcare Commission on the matter. Well, folks, the Maryland Healthcare Commission is actually here at the table in support of this bill. We don't need additional study on this. We know that this is something that works and that it is good policy. There are reports that have come out that demonstrate as well that the collaborative care model overall provides for a cost reduction for overall costs in the healthcare system. This is good policy. We are actually codifying the practice on the state side with this piece of legislation, where they have already acknowledged the fact that these copays are buried and they've removed it. Now we're just saying, hey, let's just make this consistent across the board. And I would just ask for a favorable report on this piece of legislation. Thank you, Madam Chair.
Thank you, Senator. Who would like to go next?
I can start, Madam Chair. Dan Martin with the Mental Health Association of Maryland, here in very strong support of Senate Bill 428, and thank you, Senator Augustine, for introducing it. This bill is a priority not just for us, but for the entire Maryland Behavioral Health Coalition, many of those organizations are represented here at the table. You know, we've been working for years to improve the quality of behavioral health care delivered in primary care settings by expanding access to this model, which, like Senator Augustine said, has been proven and validated in over 90 randomized trials to do just that. And the General Assembly and you all have been right there with us the entire time, and really appreciate your support. There was budget language in 2016 and 2017 studying the model. There was legislation passed in 2018 that started in this committee that established a Medicaid pilot program, and then passage of a bill in 2023 that ended that program a year earlier and just established the benefits statewide in Medicaid because of how good the outcomes were. All commercial carriers are reimbursing for it, all Medicare reimburses for it, and it's really easy to see why. There's, it's easy to see why there's been such an effort to expand this. It checks a lot of the boxes. It helps us reach a lot of our goals. It improves treatment. It reduces overall healthcare costs. It reduces disparities in access to care. It mitigates workforce challenges. But like Senator Augustine said, we're hearing from primary care practices that their patients are reluctant to come back for follow-up visits because they don't want to pay the co-pays. And like the senator said, that really defeats the benefits of the model. The symptom monitoring, the outcome measurement, the treatment modification, that really is the heart and soul of collaborative care. And so this bill would eliminate those costs for patients. It's a really simple thing that we can do to help patients in Maryland avail themselves of this care and help the state continue to expand the uptake of this model. And I urge your support for the bill. So thank you.
Who's ever next?
Thank you. Madam Chair and members of the committee, thank you for the opportunity to testify in strong support of Senate Bill 428. My name is Laura Willing, and I'm a child and adolescent psychiatrist and the medical director for mental health policy and advocacy for the Community Mental Health Corps at Children's National Hospital. The goal of this bill is to increase access to and utilization of the collaborative care model so that Marylanders can access quality mental health care integrated into the primary care setting. The collaborative care model is an evidence-based model that includes a primary care physician, such as a pediatrician, a behavioral health care manager, such as a social worker, and a psychiatric consultant, such as a child psychiatrist. In this model, the pediatrician diagnoses, treats, and manages the care of the patient with the support of the psychiatric consultant and the behavioral health care manager. In this way, patients with common conditions such as mild to moderate depression, anxiety, and ADHD can receive quality, accessible care in the primary care office. Many studies have shown that the collaborative care model improves mental health and physical health outcomes and reduces costs in the healthcare system. In fact, the collaborative care model was identified in the Maryland Healthcare Commission 2024 Behavioral Health Workforce Report as a key strategy for addressing Maryland's workforce challenges. A recent report by the Bowman Family Foundation describes that the collaborative care model is showing rapid growth nationally, especially for children and adolescents. However, the report also describes that patient cost sharing, such as copay, coinsurance, or deductible, reduce the use of the model. Given that Maryland is facing a workforce shortage of mental health professionals, that patients struggle to find in-network mental health care, and that there is an ongoing pediatric mental health crisis, we should be doing everything we can to improve access to quality mental health care for all Marylanders. I applaud Senator Augustine for introducing this important legislation and respectfully request a favorable report on Senate Bill 428. Thank you.
Madam Chair, committee members, my name is Kevin Roy. I'm the Chief Public Policy Officer for Shatterproof. We are a national organization focused on addiction and making sure that no life is defined or ended because of addiction. I've lived in Anne Arundel County for more than 25 years, and so while we do a lot of work nationally on the collaborative care model, very much understand the impact this bill could have on Maryland. And thank Senator Augustine for his fine testimony and support on behalf of this bill. And as we've looked around the country at advocating for ways to improve adoption of the collaborative care model, several things come to mind. One, as has been said, it's got incredible evidence, 90-plus randomized controlled trials that have now been reinforced by real-world evidence reports, such as just been referenced here, showing suicide risk and cost reductions across plans, across health systems that have implemented it, and certainly other states are, aggressively adopting it as well. And in one study with regard to substance use, it showed a 47% reduction for alcohol and opioid use disorder abstinence over typical care. And so that's really incredible evidence there. The second part of it is the reduction of cost. We know that only about 20% of enrollment in Medicaid is those with behavioral health, but yet it accounts for 50% of the cost. So you have a real opportunity here to look at costs, and this model's been shown to reduce costs. And finally, what I loved about the model when we got really engaged on it is the flexibility for both mental health and SUD, among other conditions. We know that people are, just logically more comfortable in the primary care setting. And so to the extent that you have a model that's flexible to address both mental health and substance use needs in that setting, we really should be doing everything we can to encourage adoption of it. And SB 428 does that. And so we here in support of that. Thank you.
Thank you. Who's next?
Thank you. Good afternoon, Madam Chair and committee members. I'm Carrie Guthrie, and I'm the president and CEO of Cornerstone. For over 50 years, we've been providing behavioral health services to children and adults in Calvert, Charles, St. Mary's, and Montgomery counties. You've heard here the great research, the great outcomes of this model, but I'm here to give you a little more story about what happens at the ground level. Our clients at Cornerstone often have co-occurring physical health issues along with their behavioral health issues. These issues are the same as the general population: diabetes, hypertension, heart disease, and people with behavioral health issues have a difficult time often following instructions from physicians regarding health. They struggle to buy and eat nutritious foods, they tend to avoid exercise, and they do not want to pay additional copays. Most of you probably know several years ago there was a study that stated that people with behavioral health issues died 25 years earlier than the rest of the general population, all for the same reasons that the rest of us might pass away, but much sooner because of all of these issues that I've shared. If we can eliminate these out-of-pocket costs, that will give Cornerstone clients and others a lower barrier to accessing care. They don't have the funds, most of them, to pay a lot of copays. They don't want to go to a lot of doctor's appointments, but it would give Cornerstone staff more leverage to support and encourage them to go to these appointments and help them get there. Cornerstone's mission is to empower people with behavioral health disorders to thrive in their community, and approving Senate Bill 428 is an obvious next step to improve access to effective health care so that they can improve their health, be productive members of their community, and have a quality life of their choosing. Please vote in favor of this bill. Thank you.
Thank you. Madam Chair, members of the committee, my name is Michael Gray. I'm with NAMI Maryland, the State Association of the National Alliance on Mental Illness, and we're just here to offer enthusiastic support for this bill. Mental health advocates generally talk a lot about a continuum of care, particularly for serious mental illness, but for all mental health conditions, and how important it is to have every piece of a system in place to provide support for individuals to get the services they need when they need them. And this is a piece that I think is often left out of that mental health advocacy conversation, is the primary care role. And that's why this model is so important, because primary care plays a role for every single individual with a mental health condition in Maryland who is getting most of the services they need where and when they need them. So for that reason, we thank Senator Augustine for bringing this bill and urge a favorable report. Thank you.
Thank you. Thank you all for your testimony. I do want to mention, if we pass this bill, it's going to apply to Medicaid and the state plans that originate in the state as well, state employees, which is about 28% of the insureds. So it won't apply to federally insured. It won't apply to plans that companies purchase their insurance out of state.
That's correct.
So I say that because we've had some other bills we've passed and people have been so pleased and then they find out
The portions
it
that-
doesn't address their insurance. So
Understood.
I just want to say
They're not in
that.
our
But
jurisdiction.
I really appreciate your testimony and your advocacy. Thank you.
Thank you.
Any other questions? I don't see any for this panel. Thank you. Next, we have Dr. Jacobs from the MHCC, David Sharp from the Maryland Healthcare Commission, and Angela Kimball will be virtual.
So just a word, Madam Chair. I'm actually sitting in for Dr. Jacobs today, and I'll acknowledge that in my testimony.
Hearings going on in the House, too, so
Yeah.
thank you for being.
But it's good to be here in front of so many people that I've worked with over the years. So getting started, good afternoon, Chair Beidel, Vice Chair Hayes, and members of the committee. For the record, my name is David Sharp, and I'm the Director for the Center for Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission. I'm here today to testify on behalf of MHCC's Executive Director, Dr. Douglas Jacobs. The MHCC supports Senate Bill 428, which prohibits the Maryland Department of Health and certain payers from imposing co-payments, co-insurance, deductibles for services delivered under the collaborative care model in primary care settings. The collaborative care model is an evidence-based, team-based approach that brings together primary care providers, psychiatric consultants, and behavioral health care managers to support patients with chronic and complex health needs. Research demonstrates that the collaborative care model significantly improves clinical outcomes, increases depression-free days, and is effective across diverse populations of care settings. Integrating behavioral health care into primary care also reduces disparities in access and supports earlier interventions. SB 428 strengthens Maryland's ability to access integrated behavioral health services by removing a key barrier to participation. Although CMS has reimbursed for collaborative care models since 2017, cost sharing remains one of the most significant obstacles to adoption. Even modest out-of-pocket costs can discourage patients from engaging in treatment, particularly low-income and vulnerable populations. Eliminating cost sharing ensures that collaborative care services are viewed as a standard component of primary care rather than an add-on requiring additional payment. The bill also aligns with federal efforts to strengthen primary care and behavioral health integration, which is consistent with value-based care principles that prioritize removing barriers to high-value care. We've also noted in the 2025 Primary Care Investment Analysis Report that removing cost sharing strengthens Maryland's primary care infrastructure. For these reasons stated, we respectfully request a favorable report on Senate Bill 428. Happy to answer any questions.
Thank you. Let's hear from Angela, and then we'll go to your question, Dr. Lamb, okay? Angela, would you like to unmute and testify?
Thank you very much. Good afternoon, Chair Beadle, Vice Chair Hayes, and members of the committee. My name is Angela Kimball, and I'm the Chief Advocacy Officer for Inseparable. We're a national nonprofit founded on the principle that mental health is inseparable from physical health. Thank you for the opportunity to testify in support of SB 428. This bill, as was just mentioned, removes cost sharing for services provided through the collaborative care model, an evidence-based approach that integrates behavioral health into physical or primary care. The collaborative care model is one of the most rigorously studied models in behavioral health, and decades of research show that it improves outcomes for depression and anxiety. It increases patient engagement, and it helps people get better faster. And it works because it supports primary care providers with a behavioral health care manager and a consulting psychiatrist using measurement-based care to make sure patients are improving. This model extends scarce psychiatric expertise into primary care practices, including those serving rural and underserved populations. It really strengthens the workforce that we already have, and it makes high-quality mental health care more accessible. However, when these services are available, cost sharing can still stand in the way. For many Marylanders, especially those living paycheck to paycheck, even modest copays can delay treatment. And in behavioral health, delays matter. Untreated depression and anxiety can lead to worsening symptoms, increased emergency department use, higher overall healthcare costs, and serious life consequences. By eliminating cost sharing, SB 428 removes a clear and predictable barrier to collaborative care. This approach is also fiscally responsible. The evidence shows that the collaborative care model reduces total healthcare costs over time by improving chronic disease management and reducing use of high-cost services. SB 428 makes it easier for patients to say yes to care. I respectfully urge a favorable report, and thank you.
Thank you, Angela. Senator Lamb, you have a question?
I'll follow up with
Okay.
Dr. Sharp offline.
I have a question for Mr. Sharp. Do we know what the increase would be, the per member per month when we eliminate the copays? Any report been done on that?
So thank you for the question, Chair Bidle. I do not have the information at hand.
Okay.
We can follow up with you on that.
Okay, I appreciate it. Thank you. I don't see any other questions. Thank you to these witnesses, and that ends the hearing on 428. I see that we've been joined by Senator Hedelman, and she has asked for us to hear Senate Bill 495 first, Health Newborn Screening Program, Gaucher disease?
Gaucher.
Okay, thank you. Senator, do you want to bring up your panel?
Yes. I think we have some folks who are virtual. That's what my confusion was. So.
Yeah, we do. We have 4 virtual. So we have you and James Romano. And who else is with you?
This is Abby Snyder.
Okay. And then we'll have everyone else virtually. Thank you.
Thank you, Madam Chair, Mr. Vice Chair, members of Finance. I'm Shelley Hedelman, Senator from District 11, and I'm here today to present Senate Bill 495. This would create a newborn screening program for Gaucher disease. Gaucher disease is a rare genetic disorder that causes a buildup of fatty deposits throughout the body that can lead to progressive organ damage, chronic pain, anemia, bone disease, and in severe cases, life-threatening complications. And you'll hear directly from some people who are affected by the disease. This is a disease that disproportionately affects members of the Ashkenazi Jewish community. Ashkenazi Jewish community are people from heritage from Western Europe. The incidence of Gaucher disease in this community is much higher than it is in the general community, and there's some data in my testimony that will give you a little bit of background. Now, you're going to hear some opposition to this bill, and I understand, and this will be something for the committee to review. I know that there is a process for putting for screening disorders and for making recommendations on what should be part of the newborn screening program. The Maryland law mandates the Department of Health screen for disorders on the recommended uniform screening panel. And that group traditionally has relied on recommendations and vetting from the Federal Advisory Committee on Heritable Disorders in Newborns and Children. And unfortunately, that group, the federal group, was dissolved in April of 2025, creating some uncertainty about the future disorders. Now, the Maryland State Advisory Council on Hereditary and Congenital Disorders established a process for nominating, reviewing, and recommending new disorders to add to the Maryland Newborn Screening Panel. And I understand, I'm sure you'll hear, I read their testimony, they believe very strongly in this process, and I respect that. And I want to raise the awareness about Gaucher disease and this importance of acting and including them. It is not expensive, as you will see from the fiscal note. It can really have, I think, a tremendous impact on children and getting the treatment to newborns that is needed from the get-go. So I'm going to stop here because we have a number of other people. This is something that is a priority of the Jewish Caucus, and I want to turn it over to my other panelists so you can hear directly from them. Thank you.
Thank you very much. I'm James Romano.
I'm the legislative coordinator for the Gaucher Community Alliance. Thank you for Senator Hellman for introducing this bill. Because the federal RUSP has been dissolved and there's no longer a process for diseases such as Gaucher disease, which is a very rare disorder, to be included on the RUSP. So the Gaucher Community Alliance has gone and started introducing bills across the country to get Gaucher disease placed on newborn screening panels. Most states are already screening for these lysosomal storage disorders. Usually it's Pompe disease, and in Maryland's Pompe disease and MPS 1. Part of that six-plex panel is Gaucher disease. So really it's unblinding the results of something that's already being used with the blood spot on the card. But the real problem is with this disease is you have type 2 and type 3, which is extremely rare, but it breaks the brain barrier. And if not caught quickly, if you have type 2 Gaucher disease, you generally be dead before you were 2 years old. And symptoms don't produce itself till 1, and then any treatment would not work. Same thing with type 3, is it's a modification of type 1 and type 2, and you will have some deterioration neurologically and physically. And there is FDA-approved treatments. So time is of the essence. What you will see is the odyssey of being diagnosed can be up to 7 years. But with this one test, we can start identifying babies quickly. So thank you very much, and I ask you favorably report this legislation.
Thank you.
Good afternoon, Madam Chair, members of the committee. For the record, Abby Snyder, Director of Government Relations for the Baltimore Jewish Council, which represents the Associated Jewish Federation of Baltimore, all of its agencies, and the greater organized Jewish community of Baltimore. We're here today in support of SB 495 as well, and I am no expert on this disease, so I'm very grateful that there are experts in the room. But the addition of this test to the newborn screening is a priority for our community because although not specific to the Jewish community, 1 in 10 Ashkenazi Jews tends to be a carrier of the disease, making it the most common Jewish genetic disease. As you'll see in the fiscal note, and Senator Hellman did mention, it's rather low in the grand scheme of things, roughly $3,600 in the first year and only going up to $5,000 to add this test. So we're thinking this is a small investment that can make a big difference for Maryland families. We hope that Maryland will join the ranks of Illinois, Missouri, New Jersey, New Mexico, Oregon, and Tennessee and include Gaucher's disease in the newborn screening program and urge a favorable report. Thank you.
Thank you. We're going to hear from your virtual panel, and then we'll do questions. So, Aviva?
Madeline first.
Okay, Madeline first then. That's not my order, but that's fine.
My name is Madeline Schloss. I live in Pikesville, Maryland, and I am a type 1 Gaucher disease patient. I was diagnosed when I was 5 years old, and my dad actually knew that he was a carrier because his mother had the disease. But when my mom was pregnant, she got tested to make sure that she wasn't a carrier, and she got misdiagnosed as not a carrier. So when I was born, because Maryland did not test for Gaucher disease, I was not tested, and I went the first few years of my life not knowing. And when I was about 5 years old, I went to the pediatrician for a normal cough, and luckily, thank my lucky stars every day, that she did a full body exam and she was able to feel my spleen, which was a big scare, and I was immediately sent to the oncology department, and it took over a month to figure out that I had Gaucher disease because my mom was told that she wasn't a carrier. So the scare and frightening weeks of this time was really permanent damage on my family, honestly, and we were lucky to find out that I was still in the early stages of type 1 Gaucher disease, and I was able to start treatment within the following weeks, and luckily today, with biweekly infusions, I'm able to live a normal, healthy life. But like Jim said, I'm lucky that I have type 1 Gaucher disease. Type 2 and 3 progress really quickly, and being diagnosed at birth would just allow these type 2 and 3 children in our area to have the best access to care as soon as possible. So while it would have prevented my family from going through this month-long struggle of a diagnostic journey, it would even more help this community of type 2 and 3 patients because of how serious this disease can get. So we are really in favor of getting Gaucher disease on the newborn screening panel for Maryland, because people like me, I've heard many stories throughout Maryland. So especially with the rare disease, even if you can help a few families just save that month-long journey, sometimes years, like Jim said, would be amazing. So thank you.
Thank you. So who would like to go next?
I'll go next if that's okay. Okay, my name is Lauren Edwards and I have type 1 Gaucher disease. Growing up, I had all the symptoms of nosebleeds, anemia, fatigue, bruising, enlarged spleen, but I was not diagnosed until 18 years old. My diagnosis was actually an accident that came when I had to do blood work for Accutane, and it showed abnormal results. After seeing a hematologist, I ended up having to undergo a bone marrow biopsy, and that's when I was finally diagnosed. Since Gaucher is often associated with the Ashkenazi Jewish population, as a Black family, we had never even heard of Gaucher disease, and my parents had no idea that they were even carriers. But if newborn screening had been available when I was born back in 1993, I could have started treatment earlier. I also was an athlete my entire life, and when I was diagnosed, the doctor was shocked because my spleen was so enlarged. He said that one wrong hit during a game and it could have completely ruptured. Newborn screening really matters, and it's important because I lived for years with preventable and treatable symptoms. Early detection prevents misdiagnosis as well as irreversible organ damage and other serious complications, and it helps reduce racial disparities in rare disease diagnosis. Because of my diagnosis, my family pursued genetic testing, and we now know that my sister is a carrier. And I'm getting married in September and considering family planning, and so the screening is deeply personal to me. I know that I'll pass this gene along, which makes early screening even more important. And I don't want my child to face delayed or unexpected diagnosis like I did. Newborn screening isn't just testing, it's prevention, and every child deserves protection from day one. Thank you.
Thank you. Okay, now Aviva.
Thank you. My name is Aviva Rosenberg. I am the co-founder and CEO of Gaucher Community Alliance. We're the U.S. National Patient Advocacy Organization for Gaucher disease. You've just heard from 2 Maryland families, patients, about how Gaucher has affected their lives. And I can tell you that working on a national basis, working with families in all 50 states, that the children, the babies that come from the states that newborn screen, have dramatically different outcomes and different stress and trauma profiles. For years, patients, including myself, I am a type 1 patient and mom of a type 1 teenager. For years, diagnostic journeys for these patients, the average time is 7 years for type 1 patients and 18 months for type 3 patients. That is time that cannot be returned. Those are irreversible symptoms that cannot be gotten back. We have permanent bone disorders, permanent bone damage. For type 3 patients, they have neurological decline that cannot be returned to them. It cannot be returned to their families. In addition, families are traumatized by the unnecessary diagnostic testing that goes on for months in order to get the proper diagnosis. Within Maryland and the greater DC area, you have some of the finest healthcare institutions in the world, including expert specialists that are internationally recognized for Gaucher disease. The funny thing is that patients come from all over the world to see these specialists, but oftentimes your Maryland own babies cannot get to the specialists until it may be too late. So we are proud to be working also with the Maryland Department of Health to advance Gaucher disease. And also we encourage you to advance Gaucher disease in any form to get on the Maryland newborn screening panel. Thank you.
Thank you very much for your testimony. Now, Senator Lamb.
Thank you, Madam Chair. Thank you to the bill sponsor and all the panelists to bring forward this important medical condition. I guess asking these questions because this has come up before this committee before. I think Senator Bailey had a bill a couple years ago dealing with Krabbe leukodystrophy and wanting to add things specifically in statute to the newborn screening panel. So there is as a baseline, totally understand that on the warpath of RFK Jr. in dismantling science, the federal RUSP, the committee that's sitting there, is a casualty of that war on science. And so, but we do have a state level committee that deals with newborn screening recommendations as well. Has this been brought forward to that? I think it's the Advisory Council on Hereditary and Congenital Disorders. Has this suggestion been posited to that council for consideration?
So yes, we have reached out to the Department of Health, but I'm going to turn it over to Jim, who has had those.
Yes, so the Gaucher Community Alliance is in the process of working through that. Initially back when I approached Senator Hedelman, we were told actually to go to the legislature. And so there was some change in the process between when I first approached her and currently that it was very positive for them to use that. And I would actually, Aviva has had more conversations, but initially we were told to come to the legislature.
By the council?
Yes, by the Department of Health, yes.
Yeah, so the process is brand new. The Maryland never had a process prior to the RUSP termination in April of 2025. So when Gaucher was originally brought up, there was no Department of Health heritable disease process. So in the interim, during that time, our patient families approached their senators and representatives to bring it to the legislature. Since we have begun that process, the Department of Health has adopted a process now to review new conditions, and we are also working through that process as well. So in fact, Gaucher disease is the first condition to be reviewed under the new Maryland Department of Health process, and so we are also doing that.
Got it. Okay, so you were suggested to reach out to us before the RUSP was KIA'd. Killed in action on the war on science.
A lot of states have what we call it RUSP alignment, and they say, okay, we're only going to put on diseases that are on the RUSP. And Maryland, up to this point, had that.
Right, we have that.
We wanted to go above, and they said the only way you can go above and beyond that is having the legislature handle it.
Got it. Yes. So our state is required to align to the RUSP. We can add more things that the RUSP has not added, but now the RUSP is dismantled. And so I guess here we are. I agree that I think that the process that the Advisory Council goes through could be better enumerated. Right? I think that could be clearer. It sounds like the department which staffs this Advisory Council is going through that process now, and Gaucher is being considered to go through this process?
Mm-hmm. Okay. Yes.
So in all transparency, Senator Layup, that process is happening, and we wanted to put forth this process too at the same time, belts and suspenders.
Okay. Because I think just in looking at the statute, the only other thing that's been enumerated in statute for coverage is critical congenital heart disease screening of newborns. So that's the only other thing that was stated in statute. That was probably added a long, long time ago. I'm not sure when that was added, but other instances we have not by statute added screening to the law. As I mentioned, there have been past bills obviously that have come through on this. So, okay.
The only, if I may, the only other thing is we're in unique times.
We're definitely in unique times. Agreed. Okay. Thank you.
Thank you all for your testimony.
Thank you.
I'm reading the testimony from the Maryland Advisory. It's very confusing, Senator. You have to help us. We have one more virtual witness, Ada Hamish, the Rare Disease Advisory Council. Okay, she'll be here in just a minute.
I'm here. I'm sorry. I was listening and I didn't know how else to do it. My name is Ada Hamish, and I am currently the chair. I'm a clinical and biochemical geneticist at Johns Hopkins. I'm currently the chair of the Rare Disease Advisory Council, which is a governor's council. And I want to let everyone know that I served as the chair of the Secretary's Advisory Council on Hereditary and Congenital Disorders from 2001 to 2009. So the statute that establishes that council is from 1984. There has been a process to consider new conditions for newborn screening since well before 2000, because there was already a process in place. It's actually a very rigid process in place right now. We have always considered which conditions to add. And I'm happy to discuss any conditions, but I really don't want to. What I want to say is we have a really good process in the state. Alignment to the RUSP only happened in 2024. So we've been considering and adding conditions for decades. We are a good state. We are blessed to have many experts on newborn screening, lysosomal storage diseases, other inborn errors of metabolism. We have a system in place. We should go by that system. It is not a good idea to legislate conditions. My immense respect to the senators and delegates who serve on all these committees and make amazing decisions about unbelievably complicated topics. This is one of them, and you know what? We've got people in place who are experts to deal with it, and that council is mandated not only to have, clinical experts, but it's got representatives from the health department, from different general practitioners, and the public, and patient advocates on that committee as well. So it's a very well-composed committee that takes its work extremely seriously. Please don't legislate individual conditions. Thank you.
Ada, thank you. But I heard in testimony that they were told to come to the legislature. Senator Hellman, is that correct? Were you directed to come to the legislature?
I was not. I did not have those conversations.
GCA was directed to come to the legislature. That's what we were told. We would have, and then we also have we were told then, we were contacted by the committee after we had come to Senator Hellman, and they said, please put in an application, and we have since done that.
Okay.
But I do have to say I disagree. I believe it's patient advocates who come to their legislators asking to add a disease. I think that's it's not a bad thing. I think it's actually advanced citizenship. With Gaucher disease, what our major concern is that we were getting some pushback by not Maryland, because they actually contacted us then about to Aviva about 9 months ago when we started the process, but we've been working with the senator. I still think that it's great for advocates to come ask, because if the Heritable Diseases Committee declines to add Gaucher disease, which I'm not saying they are, I'm not saying they aren't, if they decide to do that, we have nowhere to go. If we come to the legislature and you add it or don't add it, then we have an advocacy campaign to do that, to add it. So I feel like it's incumbent upon a disease group such as Gaucher to come to the legislature, ask you to put our disease on there, so that if I know that we've been trying this similarly in Pennsylvania, and they've been holding meetings, and we've been basically discarded several times without even being in the room. And so we had nowhere to go but the legislature. And so that's why I feel I disagree. I think it says advanced citizenship that we should work to get this placed on there. I'm not suggesting that I think we will be accepted onto the Maryland one. I think on February 24th, Aviva and a whole bunch of patients are testifying to the committee. But I think that it's also incumbent upon us to ask you to do it too.
No, Mr. Romano, it's fine that you came. My confusion was I heard that you were told to come to us, and I'm hearing from Ada that they don't want you coming to us. So I'm just confused by the process. But you may be too.
We reached out, and we were told that no, that it was RUSP aligned, and that since we weren't on RUSP, this is before the RUSP was. We were in the process of putting together a campaign to go on RUSP. I don't know if you are familiar. That costs upwards of $500,000 for an organization to put together the right package when the RUSP was there. It was not it was a very hard process. And now, and now that the secretary has gotten rid of that process, for small groups like GCA, this is the only thing we have in to be able to do. Sorry.
Senator Jackson, did you turn your light off? Okay, Senator Lane.
Yeah, thank you. And full disclosure, I also serve as the Senate designee to the Rare Disease Advisory Council that Dr. Hamouche chairs, although she and I have not talked about this bill. This is the first I've kind of seen of this. I think, I do think it's curious that the Advisory Council or their staff told you to come here first, because I think that's probably not the proper guidance. I think that's why there was deferred authority to the Advisory Council to kind of make the first decision and first pass at all of this, to kind of weigh the sciences. There are pluses and minuses to adding things to the screening panel and whatnot, and I'm sure Dr. Hamouche could go into that. But, I think the proper channel that you should have been directed to by either the Advisory Council or MDH staff is to actually go through the Advisory Council for them to fully go through their process. That said, here we are, obviously, and so we're trying to figure out, what to do with this. I think the 18 months that the RUSP or that the state has to align with the federal RUSP requirements was actually the result of Senator Bailey's bill. So, back in 2024, when we passed that legislation, that was the compromise to require our state to align with federal recommendations within 18 months. And that was as a result of Senator Bailey. So with what we're seeing here now would it be fair? I guess one way to look at this is to have some type of reporting back to the General Assembly on the progress that the Advisory Council makes. And so maybe that's something that if we are motivated to pass something, it may be a reporting requirement, similar to how we have a lot of insurance mandates that come forward, that those are considered by the Maryland Healthcare Commission initially for a year, and then a recommendations provided by the MHCC back to the General Assembly for us to kind of review and then decide whether to implement that as a payer change requirement or not. In this instance, perhaps we can look at something that might require the Advisory Council to report back to us on what they decide about Gaucher. And this is obviously a new process. We're obviously all going through this at the same time.
I think that's wonderful. Like I said, the committee came to us then and said Gaucher should submit an application. And like I said, I believe it's February 24th, we're having our hearing. And so I think that's wonderful. I will say this, some states are phenomenal and with their committees, and some states aren't. And I could point to Pennsylvania and say it's a very flawed process. I always believe in sunshine, so yeah, reporting back to the legislature would be fantastic.
Right. And for Dr. Hamouche, you're the chair of the RDAC, but do you also serve on the advisory? I know you said you served on the Advisory Council. Are you currently on?
It's a conflict of interest for me to serve on both, I think. But the Hereditary and Congenital Disorders panel, just so you all know, there's probably 8 or 9 physicians and laboratory people that attend those meetings who aren't on the council because we care that much about newborn screening. So it is a really, so I go every month. I haven't served since 2009. Okay, I occasionally I can't go, but I go every month. Carol Green from University of Maryland goes every month. So that this is we care about newborn screening. We care about public health. Many of us are double degreed in and we really care. And in terms of and I don't want to address Gaucher at all, but in terms of decisions for when we say yes or no, you are absolutely right that it is patient advocates should be advocating, but sometimes decisions, and I'm not talking about Gaucher here, but sometimes there's lots of other elements that go into making a decision about the test might cost nothing and it might already be very easy to do, but sometimes the test costs a lot of money. Sometimes the evidence for the efficacy of treatment isn't there, or the risk-benefit ratio for treatment. There's a lot of different reasons, and there are certain people who think, I want to know everything the second my baby is born, no matter what, and obviously those are big advocates for screening. There are some people who are like, well, if I had had those 6 months before I knew something terrible was going to happen that you can't help me with, I would have been a happier person. And that's a very, it's a personal decision. That's not for legislatures or anybody else, but it's complicated. And the committee has very clear criteria. Newborn screening is a program. It's not, it really has to be considered thoroughly, and it is by the Secretary's Council on Hereditary and Congenital Disorders. They have a very detailed process. You will see it when you're presenting next week. I'm sure you were asked to bring experts. There are people who speak for and against. It is exactly, but less expensive than the federal process, and always has been. Because we did not have to be RUSP aligned until 2024, and we still brought on conditions. The reason for the alignment was because there were delays by MDH funding of implementing those things. That's why that bill was changed. We wanted some conditions 3 and 4 years before they were implemented, which is why that 18-month was put in, and all in favor, yes. You know, I mean, I'm not sure MDH is in favor because it's hard to do. But in any case, there is also, separate from the federal government, national efforts to sort of recreate that advisory committee through the auspices of the American College of Medical Genetics and Genomics, because we do need a federal system. Well, it won't be federal because it can't be right now, but we do need a national system so that, you know, in this state, we have the expertise. In other states, they do not. There's not a biochemical geneticist in the state of Idaho. They've got to follow something else.
So just to kind of conclude on the point that you were making, so the advisory council looks at a whole bunch of different factors, right? And not to single out Gaucher, but you know, they're looking at how what the incidence is, the false positivity rate, how many people are impacted. You know, all those factors are considered as part of the advisory council in their process then, right?
Correct.
And
how
so
treatable, how easy
that
it
all
is
has to be
treat,
weighed.
who, how much that costs, whether it's available. There's many, many things that go into deciding a condition that is appropriate for newborn screen or not. And there are a few conditions that have been controversial, and there are reasons for the controversy, state by state or on the RUSP. But there is a method to present it that should be brought forward. It should be considered carefully. And, you know, we're lucky in Maryland. We have a system that works. And legislators, I mean, Dr. Lamb, you're a doc, you can do it. But it's a lot of stuff. And it's not something that in a busy legislative session, considering thousands of bills on every topic imaginable, that you should have to think about the specific, this particular condition and whether it merits newborn screening.
And if we, I guess one possibility if we were to move forward with this is maybe to also just have the advisory council have a clearer process. I think they're working through trying to articulate a clearer process. I think that's maybe why there was some confusion, communication that happened here. But, you know, I think in many ways they've been able to rely on the federal RUSP program. And since now that's been effectively dismantled, they're having to really stand up a structure in place and work out what that process and structure is to be able to evaluate new conditions, additional screening tests that come forward like this one. You know, maybe something that can be included about just a clearer process for the advisory council.
There is a written detailed process, which I'm sure, I can't speak for the council, I don't even serve on it, but I'm sure they'd be happy to share that with the committee or with the legislature in any way. I mean, it's been extant for at least a decade, possibly longer, you know, so that it's way before the RUSP. We existed and we're doing this before the RUSP.
And maybe also just a reporting back.
Yeah.
Yeah. Okay.
Happy to, have that conversation.
Yeah. Thank you.
Thank you for clearing up that confusion, Senator Lamb. That ends the hearing on Senate Bill 495. Thank you. And Senator Hellman, if you'll stay there, you're going to bring up Amanda Rodriguez from the Maryland Human Trafficking Task Force, and we're going to hear Bill 473. Public utilities for hire drivers and transportation network operators. Thank you.
Thank you, Madam Chair. Very different topic, but I'm very happy to be here. For the record, Shelley Hedelman here to present on Senate Bill 473. This bill really builds on the work of this committee and the Maryland General Assembly to continue trying to identify and provide resources in the community to help people who are being human trafficked. This bill requires that drivers of licensed taxi cab drivers, for-hire drivers, and transportation network drivers participate in a prevention program, awareness and prevention program on human trafficking. There is one that is available, and I believe pretty well respected, from the Department of Transportation that already exists. These companies will not, and businesses will not be required to reinvent the wheel. We tried to make it as low barrier and least cumbersome as possible to them. to fit into the licensing requirements that drivers already participate in. We do believe it will go a long way to help them identify people who are potentially being trafficked, and I'll let Amanda talk a little bit more about the specifics of trafficking. I will say, Maryland is in a unique geographical spot with regard to this particular issue, being along 95, being, up in the East Coast corridor. We are both the destination and transit point for different kinds of traffickers. And she can talk some about that. The bill provides civil and criminal liability protection for licensed drivers who report or respond in good faith to suspected human trafficking incidents, and it does align with broader national efforts to engage transportation professionals in anti-trafficking work. The U.S. Department of Transportation has taken a lot of work on this in terms of other kinds of workers in this industry, and we in Maryland have required a lot of awareness training also. I am happy to answer questions, but I'd like to turn it over now to Amanda, and I'm happy to answer any questions that you all may have. Thank you.
Madam Chair, Mr. Vice Chair, my name is Amanda Rodriguez. Members of the committee, I am the chair of the Legislative Committee of the Maryland Human Trafficking Task Force. The task force was formed in 2008, and it's made up of law enforcement, victim service providers, survivor leaders, and government agencies, in addition to local task forces that work on this issue collaboratively. We facilitated the recovery of thousands of survivors since our formation and prosecution of hundreds of human traffickers statewide. Human trafficking is a crime that is hidden in plain sight within our communities. Unfortunately, it is in every single county jurisdiction in the state of Maryland. Training of those who are most likely to interact with a survivor, especially when they are away from their trafficker, is an important step to the identification and recovering of survivors here in Maryland. Most of the survivors that we work with at Turnaround, and we're serving hundreds of survivors a year, utilize taxi services, rideshare services, in an ability to get from where their trafficker is to where the sex act is to occur. As the Senator Hettleman spoke about, there's a lot of misconceptions about trafficking, that it involves being locked in a basement or it involves, being stolen off of the streets. Trafficking really is happening within our communities, and often the trafficker is in a different location than their victim ultimately. So they're utilizing different transportation means to ensure that their victim gets to the place that they are supposed to be in a way that they think is the least possible criminal liability for them. And in this case, that would be rideshare services or Uber services or taxi services. There is already training, as the Senator spoke about, on this that's utilized by the Department of Transportation. It is a good training. It was done in collaboration with the Maryland Human Trafficking Task Force. The task force has also provided written testimony with some additional information. And as a result, we will ask for a favorable report for HB 473. Thank you.
Amanda, it's nice to see you again. Thank you for the work with Turnaround.
Thank you.
It's really interesting, recently following the issue with the Epstein files and listening to the victims, you would think someone would have picked up the issue and reported it, so this could be an important answer to some of those issues. Absolutely. Do I have any other questions for this panel? Thank you very much.
Thank you.
Thank you, Senator Hettleman. Okay. Senator Hayes, Senate Bill 469, Maryland Automobile Insurance Fund Affordability.
Let's see. Cool. You ready? Thank you. Good afternoon, Madam Chair, members of the Senate Finance Committee, at least those who are left. I'm here today to present Senate Bill 469. Senate Bill 469 ensures that eligible drivers who cannot obtain coverage in the private market have access to affordable insurance through MAIF by authorizing the creation of a dedicated affordability program. To date, Maryland drivers are facing some of the highest auto insurance premiums in the nation, with rates soaring to an average of over $4,000 annually, more than double the national average, and over 53% increase from previous years, in addition to increased prices in groceries and amongst other things. So the question, rent, electricity, you name it. So the question is, why are Maryland drivers paying such steep rates for auto insurance? The answer lies in the various complex risk factors. Maryland's unique risk environment plays a significant role. Most Marylanders are overburdened with commutes through congested metropolitan areas like Baltimore and D.C. This heavy traffic leads to frequent minor accidents and heavy volumes of claims. According to the Maryland Highway Safety Office, on a 5-year average, there were a total of 107,886 car crashes. Of these, 535 resulted in a fatality, 28,609 in personal injury, and 78,742 in property damages. Additionally, approximately 12% of Maryland drivers are uninsured. This means over 400,000 uninsured drivers on Maryland roads, including those with Virginia tags. When uninsured drivers are involved in accidents, the financial burden shifts to uninsured drivers, further increasing premiums. Maryland also faces exposure to extreme weather events, including flooding and hurricanes, all these factors accumulating to inflated premiums. Because auto insurance is mandatory in the state of Maryland, these inflated premiums also function as a financial burden. For low to moderate income families and households, even a modest monthly increase can mean cutting back on groceries, delaying utility payments, or using credit cards to cover bills. When premiums become unaffordable, constituents may forego coverage altogether, increasing risk for everyone on the road and limiting their access to employment, health care, food, and essential services. Senate Bill 469 provides me with clear authority to implement affordability programs that stabilize coverage for underserved drivers. By codifying this into law, we can reduce the number of uninsured drivers on our roads and promote safer, more equitable access to transportation for all Marylanders. For these reasons, colleagues, I urge a favorable report on Senate Bill 469.
Thank you, Vice Chair Hayes. Good afternoon, members of this committee, Chairwoman Bidle. My name is Devon Brown, and I am the Government Relations Manager for Maryland Auto. Obviously, we support Senate Bill 469, and I just want to thank Senator Hayes for his leadership on this bill. And of course, I want to thank each and every one of you for your continual leadership and making sure that we keep Maryland drivers on the road legally. I just want to thank you guys for allowing us to be here, and it's my honor to introduce our Executive Director of Maryland Auto, Mr. L. Redmer.
Thank you, Devon. Madam Chair, members of the committee, thank you, Senator Hayes, for introducing this. You have my written testimony. I'm not going to read it, but I'm here on behalf of all of the employees at Maryland Auto in support of Senate Bill 469, which codifies our mission of serving Maryland citizens. As you know, we were created 50 years ago by this General Assembly to provide coverage to folks that can't get it in the standard market as an effort to keep people insured that would otherwise be uninsured. 40 years ago, the General Assembly, recognizing that some folks are uninsured simply because they can't afford it, instructed us to consider affordability in our rate making as part of our mission, and we've been doing it ever since. In December of 2024, the MIA issued an order requiring us to do a couple of things, including requiring us to have adequate rates, and that was modified to say until the end of 2027. So adequate rates, that means we have to have enough premium to pay our claims and our expenses. to have adequate rates today, we would have to raise rates in some low-income communities between 30 and 53%. Now, the folks that are in high-cost areas that get an increase of 30 to 53%, they're not going into the standard market. They're going to drive around uninsured. Now, the reason for the MIA order is they recognized a conflict in the statute. So when we were directed to look at affordability 40 years ago, the legislature did not remove a provision of the statute that requires us to have adequate rates. So there's a conflict, affordability or adequate rates. With the folks that we insure, you can't do both, again, without raising rates 30 to 53%. So Senate Bill 469 was originally drafted solely as a mechanism to codify what we've been doing for 40 years. Now, as a result of us meeting with the MIA, we are working with the sponsor to create some amendments that would add some guardrails to the scope of affordability as we create our rates, and you'll be seeing more of those amendments shortly. But I would like to address a couple of issues. Number one, we look at affordability when we create rates. We are not affordable. We have the highest rates in the state. I invite each of you to call your local insurance broker and say, give me a rate from Maryland Auto, and you'll see we are not affordable. Secondly, there's been comments about solvency, concerned about we would become insolvent. We cannot be insolvent. The legislature created 50 years ago an assessment mechanism that makes it impossible for us to be insolvent. Now, as you will recall, last year we triggered an assessment. That assessment was $19.5 million. It equals about $3 for every $1,000 of insurance premium. So if the carrier that insures you passed that along, your $2,000 premium became $2,006. Contrasted by the surcharge on health insurance premiums that we're about ready to levy, there's going to be $27 per thousand. Now, I believe that we provide a value to every policyholder in the state, regardless of who your coverage is. If you go and you look at your policy, you'll see that we all pay for uninsured motorist coverage. If we get hit by an uninsured motorist, our insurance pays for it. We all pay $50 or $60 a year for that. If you look at DC, where they don't look at affordability, they pay a much higher amount, over $100 for that same coverage. So that differential, from my perspective anyway, is a direct, tangible benefit that we provide every policyholder in the state because we're keeping folks insured that would otherwise be uninsurable. Now, I mentioned that the assessment last year was $19.5 million. We'll be closing the books in the next week. Our assessment this year is going to be somewhat less than $7 million. So that $7 million is going to be equal to $1 or $1.25 per $1,000 of benefit. Again, I think the tangible benefit that we provide every policyholder is significant. So in closing, Madam Chair, this is it's a simple question. It's not complicated. It's to allow us to continue what we've been doing for 40 years and have a moderate assessment, or we end up increasing rates in low-income communities by, again, 30 to 50%. So with that, Madam Chair, we're happy to answer any questions that you might have.
Thank you, Mr. Redmer. Senator Washington.
Thank you, Madam Chair. And looks like you got a lot of time there, buddy.
I yielded the balance.
That's exactly what I thought.
I will say for me, that was pretty brief.
I pressed the button just so you can continue anyway. So
thank you.
So good work. You mentioned in your last comments that you're gonna, if we don't pass this bill or something similar, the insurance rates are going to increase for the high-risk motorists like college students or folks that have, can't find an adequate insurance because other folks are just denying them, so they go to you for the last resort, and which is already non-affordable. You said it would be 30 to 40%. How many folks are we talking about throughout the state?
So we insure currently about almost 28,600 individual policies, and how many do we
26,000?
have with the affordability index, Joe? Little under 7,000.
Got it. And that affordability index would just go away, essentially.
Correct. Yeah, we'd have to have adequate rates. Correct.
MIA, when you were created, they created this policy, and now they're they're going to remove that.
Well, no. So the looking at affordability in creating our rates was put in our mission by the General Assembly.
Yeah.
The MIA regulates us, and so they believe that conflict between having adequate rates and affordability, we need to have adequate rates. They've given us till the end of 2027 to do that. I will also point out, they also don't like how we look at affordability because and this bill does not address that. We currently look at affordability based on geography. So it's low-income communities that are in high-cost areas. At their direction, we are going to change that. We're going to modify the mechanism so that we look at it based on the individual policyholder instead of an entire community.
Okay, sounds like we're getting into geography a little bit, but that's another bill.
Yeah.
Did you sit on the affordability, the auto insurance affordability work group?
I did.
You were one of the members on that board.
Correct.
In that work group, they made some recommendations, not really recommendations. They kicked the can down the road. They kicked the can to the legislature. They told us that we should continue to study certain things, which was just kind of pointless of having a work group if you're not going to really make some recommendations to the legislature. But one of the things that they pointed out that seemed like, according to the director of MIA, is that you all came to a consensus on all of these and all these recommendations and that you made to the General Assembly. And one of them was for you guys to get rid of this affordability index and to change the affordability index and to change your rate making in there too.
So I don't recall our rate making or the affordability index being part of any recommendation that came from the work group.
In the report, which I read in full, it made a recommendation for your agency to change the way you're doing business, which is what they're recommending now.
So my recollection is the only thing, and we'll go back and look at it, the only thing that was in the report specifically dealing with us is the recommendation that we go from a 12-month policy to a 6-month policy. But we'll go back and look at it to make sure.
Yeah, I think you should, because it'll be confusing to see that you all agreed to this as a member of that committee, and for this to be one of the
no,
bills that
we
you
did not
proposed.
agree to anything with the work group that impacted Maryland Auto specifically, again, except for the option of going from a 12-month policy to a 6-month policy.
Okay.
But again, we'll go back and look at it.
I'll take it as that you don't agree with that policy. That wasn't a consensus policy
To change the
for that
affordability,
recommendation.
yeah, we're working with the Insurance Administration to change the mechanism that we use to deal with affordability. But no, we in no way support an effort to remove affordability from our mission, because I personally believe it would be catastrophic to the marketplace. If we raise rates in low-income communities 30 to 50%, again, they're not going to some other carrier. We're already more expensive.
Right.
These folks are going to drive around uninsured. They're going to hit things, and the cost of uninsured motorist coverage for all of us will increase significantly if we're forced to abandon affordability in our rates.
Got it. Thank you.
So I'm going to, Senator Jackson.
Okay. So, and this is for anyone, Maryland Auto is an independent state agency, correct?
Correct.
And auto insurance companies are considered financial institutions, you would say?
I assume so.
So why do you think they're coming out against this bill? Like, do you have an opinion?
So I haven't heard that they're opposed to it, but that could very well be. I can tell you, having served in the legislature myself and having served as insurance commissioner twice, the standard insurance market has historically opposed just about everything Maryland Auto has wanted to do for whatever reason. So again, we exist and I'll tell you a story. Larry Hinton, who was he was their lobbyist for Geico 20 years ago, was complaining about MAIF. And I said, if you don't like MAIF, make them go away. He said, well, how can I make them go away? I said, stop canceling people. So we exist because other insurance carriers don't want the population that we serve. Ironically, disproportionately, the people that we serve are in low-income communities where we have the highest rates. So why is that? I don't know, but somebody has to serve these folks. We do it. When I began my remarks, I said I'm here because representing all of our employees. Our folks believe in the mission. We serve Maryland citizens every single day. The value that we provide, I think, is benefiting every policyholder in the state, and it also benefits those carriers that, for whatever reason, don't want the folks that we serve.
Well, I think that's where I'm confused, because if you're taking the folks that they don't want, the high-risk folks, what is the issue?
They don't want to pay an assessment, I guess. But bear in mind, every assessment gets passed on. And assessments, there's a residual market in every state of the union. There's plenty of assessments in other states. They have a choice on what they do with the assessment. Number one, they can eat it. Well, let me tell you, nobody's eating it. Option number two, if they choose, they build the expense into all the other expenses and they get built into the rate. So as an example, every insurance carrier pays an assessment to the Maryland Insurance Administration every year. That gets built into the cost, gets built into the rates that we all pay. And then finally, some carriers may choose to recoup the assessment through individual policyholders. So if your carrier did that, your $2,000 premium last year is $2,006 this year. If it's $2,000 this year, next year, because of our new assessment, it's going to go from $2,000 to $2,001 and some change. Again, I think that's a great value that we provide every policyholder and we provide the industry. They should be endorsing and celebrating what we do.
Thank you, Madam Chair.
Okay. So there's a little more to this story. The reason that I believe that the MIA, they didn't particularly like how you addressed the affordability.
Correct.
And I think we've looked at, tried to find other ways, because when you choose a zip code, like if you pick Annapolis 21401, you're
Correct.
giving the subsidy to everybody in 21401. Have you seen the $2 million homes in 21401? Because it would apply to every driver that needed Maryland Auto Insurance Fund. We are the, correct me if I'm wrong, Mr. Redmer, we are the only state in the country that has Maryland Auto Insurance Fund, an insurance fund.
Correct.
All the other 49 states have assigned risk.
Yes.
So every company has to take their share of the market.
Correct.
And so this is a different way to do it, but maybe it's time to look at what the other 49 states are doing.
Sure.
Because, I mean, every company's paying a share of the inadequate rates. And if they have to take assigned risk, they're going to pay their share of the bad driver.
That's what.
We are very possibly the most expensive state for auto insurance rates for a lot of reasons. And other states have done things differently. They have addressed the legal issues, for lack of any other way, I'm going to say that, and brought in more companies to be more competitive. We haven't done that. So I think Maryland needs to look at how we address auto insurance and how we rate auto insurance. I'm not proud to be the most expensive state in the country. So I think there's a lot more to do here. So
Absolutely.
this bill is just a little piece of what's going on with auto insurance. And I think we're going to hear from some other people in opposition.
Yep.
I don't see MIA on my list. They may have written testimony, but I don't see them on the list today.
MIA has supported testimony that's informational only in nature.
Informational.
And that's as a result of both MIA and MAFE have come together and looked at some of the amendments and the guardrails that have been provided to narrow the focus on it. And so they have not come in opposition. They've come in.
And Madam Chair, if you don't mind, the zip code, as we've discussed before, we are going to transition based on the MIA request to a individual policyholder basis instead of using the zip code. And I would invite you to check with the MIA. Back when Commissioner Kathleen Borain was there, she contacted IPSO, the nonprofit, national nonprofit that does work for residual markets around the country. And Kathleen Borain asked them for a quote just to do underwriting in an effort to consider replacing us. She got the quote back, called back and said, there's something wrong, this seems too expensive. They told her, we cannot do the work for the amount of money that it costs MAFE to do the work. And when we release our financials in March, you're going to see that our general and administrative expenses for multiple years now are going to be below 11%. I would put that expense load against any carrier in the country.
But the assessment's because of the subsidy, correct?
I'm sorry?
The assessment that you have to apply to all other insurances because of the subsidy.
No, not at all. No, it's based on revenue and expenses. The assessment deals with the surplus, but general and administrative expenses are not impacted by the assessment at all.
But it's because you can't charge adequate rates. It's because you're not charging adequate rates, and that's why there's an assessment to.
Oh, yeah, the assessment is based on the fact that we have inadequate rates. That's exactly right.
What's the decision with the 6-month policy? Are you
So we are hoping to pursue that, but from an actuarial perspective and a technology perspective, we've got to redo all the technology. It's going to take a while. I can't tell you how long.
Will you be able to bill monthly? Because I don't see loan companies taking on a 6-month policy rate.
So we will, and you'll recall the General Assembly 2 or 3 years ago gave us permission to improve our installment billing program, and we have a much higher percent. It used to be 2%. 98% was through the premium finance company. I think our installment billing is now up to around 30%. So we've made great improvements there as well.
But you haven't changed, you're not a direct writer. You always have to pay an agent commission?
Correct, that's right.
So that's another issue. You
Yes,
can be doing all the work and another agent needs to be paid commission.
Yeah, that's another bill.
Okay, that's another bill. Okay, this year is another bill this year?
Yes.
All right, thank you, Mr. Redmer. Senator, do you have something else?
No, I just want to say thank you to the committee. You know, in looking at this bill, I once was a customer of MAFE as a young college student, and you know, I've always been frustrated. I think both myself and Senator Washington sponsored bills about the disparities as it relates to insurance rates here in the state of Maryland, and recognizing that, especially communities that we represent, where there's so many people that, especially on low fixed income, the theme of the session is affordability. I think that, you know, if the legislature, as we intended, to have this separate entity to have high-risk customers, that we should also have something in place to provide it, you know, to prevent people from going to, you know, being uninsured. I know, like, I am so overwhelmed by these Virginia plates. And I mean, literally, like, they drive recklessly, they're everywhere, they're proliferating the road, and they're here because of, you know, the cost of insurance. And so what attracts me to this piece of legislation is the fact that that MAIF seeks to remain affordable to some of the individuals in our community that are hard to insure otherwise. And so hopefully, I know there's other PAC, this is just a small piece of it, but hopefully through our deliberations and considerations of this legislation and other things that may come before us, that we could find a happy medium. Thank you, Madam Chair.
Thank you, Senator. We'll have more discussion on the voting session, I'm sure. I don't see any other questions for this panel. Thank you.
Thank you, Madam Chair.
Thank you.
So next we have the unfavorables. Surprise, surprise. Robert Enton, Bryson Popham, Nancy Egan, Lauren Packman.
Sure. Yeah. No tossing of the coin.
Madam Chair, members of the committee, Bryson Popham, on behalf of several clients here, the Maryland Association of Mutual Insurance Companies, the independent insurance agents and brokers, really the entire industry is opposed respectfully to Senate Bill 469. I did visit the sponsor's office earlier this week, and I continue to offer to hopefully have an open dialogue on the issues that he has raised, which are important. There are two subjects in the bill. One's affordability, and one is the language that MAIF has just supported. The affordability issue, I hope the committee agrees that it's a broad issue. It's a big issue. Affordability in auto insurance is the entire industry. It shouldn't be limited to a company that has, or an entity that has about 1% of the market, which is what this bill would do. So, Madam Chair, you asked some very pointed questions earlier, and I made mental notes of those, and I hope those questions are included in our continuing discussion of affordability. I certainly would support that. With respect to the language that gives MAIF the authority to create an affordability program, I'm astonished. I've never seen anything like this, and I respectfully suggest to you that what the bill is asking you to do is to cede your statutory authority over a very important issue, policy issue, that is rate making by an insuring entity in Maryland. And not only that, it takes authority away from your regulator, the insurance commissioner, in the same breath. So for those reasons, it's so broad. I would simply encourage the committee to read the Insurance Administration letter of information, which in no way, in my opinion, can be taken as supportive. And I would point out to you that we have almost 20 million this year, more millions next year and the following year. We don't want that to continue. We will work with you to see that it does not continue. We respectfully request an unfavorable report on Senate Bill 469.
Thanks. Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the committee. Thank you for the opportunity to speak today in opposition to SB 469. My name is Lauren Packman, and I am Legislative and Regulatory Senior Counsel for Allstate in Maryland. SB 469 undermines a core solvency safeguard by authorizing MAIF to create an affordability framework that could conflict with Maryland's rate-making laws, which prohibit rates that are inadequate, excessive, or unfairly discriminatory. Allowing MAIF to knowingly set rates that are inadequate threatens their solvency, and I'll get back to that in a second, and exposes Maryland's taxpayers to avoidable financial risk. Affordability shouldn't be achieved at the expense of solvency or consumer protection. I did hear Commissioner Redmer say that MAIF statutorily cannot go insolvent. I think what that means is just that MAIF can collect assessments when it runs out of reserves to not go insolvent. That doesn't change the definition of solvency as relates to MAIF. So I don't think it's as simple as just saying that solvency is not a concept that should be applied to MAIF. It does still apply. I was pleased to hear Commissioner Redmer say that he's working with the sponsor to develop guardrails, and I hope that those might include eligibility standards and a definition of affordability. The framework wouldn't require legislative approval or actuarial feedback or any transparency around how it would be funded or sustained, and it would shift the burden of responsibility from MAIF policyholders to presumably future assessments on Maryland carriers or rate increases. MAIF's choice to charge inadequate rates doesn't fix anything. It just moves the financial gap to be the responsibility of other carriers and their policyholders. This means drivers in the standard market will be subsidizing MAIF drivers, and that'll distort the overall Maryland auto insurance market. For those reasons, we respectfully request the committee issue an unfavorable report on SB 469. Thank you.
Good afternoon. My name is Nancy Egan with the American Property Casualty Insurance Association, and our members write 67.4% of the personal auto market here in Maryland. I have met with the staff of the sponsor, Senator Hayes, and we've told him of our opposition. There's several things that's going on in this bill. First of all, there's many people that are of low income and moderate means that are insured in the regular market. And every time there is an assessment to support MAIF's current policies, we're paying the additional cost for them to keep not having adequate rates. In addition, the study that was conducted by the MIA was in 2023. But prior to that, there was a bill submitted in Senate Bill 903, which resulted in the study. And what had happened is that MAIF had come to the legislator asking for some money. We asked a study to be done, and in that bill, they were able to get some money that had been held from a prior assessment back in 1989 of $9.7 million, and an additional $2 million that came out of the state general fund to support them. When they did the study, that's when the MIA found out how they were defining affordability. There was no disclosure of that prior to that. We were all unaware that this is what they were doing prior to that. And it was through MAIF's, the MIA's regulatory authority that we found out they were supplementing rates across large swaths of territories just based on a general assumption that this area had less income than other areas. I live in Baltimore City. Part of my zip code is one way, and part of the other zip code is the other way. So if I had been insured with MAIF, you know, obviously I have an income, I would have been getting my rate supplemented because just based on zip code. For those reasons, if you look at the assessments in the MIA testimony, it's also of concern. And Senator Washington, one more thing. I did serve on the task force, so I just wanted to let you know. Thank you. Thank you.
So I guess this is probably a question for an insurance company, so Allstate, you're at the table. If we didn't have MAIF and you had to take your share of these, I don't know what to say, some are bad drivers, some are just not had prior insurance, some have poor credit, but if you had to take your share of these clients and these losses, how do you think that would affect the profitability of your insurance company?
I think it would end up, I mean, there's a reason, right, that there are certain policies we don't write because our underwriters determine that the risk is not something that we can absorb and
risk
remain
meaning your
solvent.
Losses would be higher.
And so our losses would be higher, and inevitably those sorts of things get passed to consumers and policyholders, so our policyholders would end up paying more.
So the reason I'm asking that is one way or the other, the insurance companies are going to be affected, whether it's an assessment or insuring high-risk drivers. Your bottom line is going to be affected.
That is true.
Okay.
I don't think that changes our position on the bill, but
not on this
I think
bill.
that is
it doesn't.
true.
But you know, we've been talking about the affordability of automobile insurance in Maryland for many, many sessions, and we're not making any progress. And so, you know, MAIF is just one piece of the problem. And Nancy, I agree. The affordability issue, the subsidy, would be applied to everybody that has MAIF in that zip code, but not to all the other people that pay insurance in that zip code. They're not getting benefit of a subsidy, and they may have low income too. So, you know, that's not fair. How do you feel about insurance agents receiving commissions on policies that MAIF is actually writing and servicing? Should we change that? Does that help MAIF's bottom line? if they're not paying commissions on those policies that they're writing?
May I?
Yes, please.
As the agent representative at the table, our members, that is the insurance agents and broker members, use MAIF for its intended purpose. That is, as a market of last resort, not a first resort.
No, I know.
Of last resort. And they have, there is a bill in, as you know, another bill that affects commissions paid to producers. They are not taking a position on that bill.
Okay.
They have never, in my 40 years of representing them, come to this legislature and said, pay us more.
Okay. I haven't seen the other bill yet, Bryson. I've been dealing with the first 200
you will.
bills that we have.
It's coming your way.
we'll look at
And I would say that most agents, I think I can speak for most agents, certainly the ones that I represent, they do not, for them, providing MAIF coverage is something that they do as a service. It is not a central part of their.
Right. I appreciate that. Thank you. Senator Hayes?
Yes. Thank you, Madam Chair, and thank you so much for this panel. And I appreciate each one of you. I know you all have reached out prior to this hearing to let me know that you were coming in opposition. I expect nothing else, and I appreciate that. But so I'll take it light. But for the life of me, every time I go to a community meeting, people ask me the same question. And so I'm going to ask you, why do we have so many Virginia license plates here in the state of Maryland?
I want to let you know that I was over in the House building today, and when I walked over, because there was a press conference going on, I noticed there was a bunch of limos out front with Virginia tags, and I was like, who is coming here with Virginia tags? Right. No, I was just laughing that the limo, the black cars, but yes, I was thinking the same thing, like why, they are going across state lines. What we were just wondering, Senator Hayes, is that in Virginia, they tax automobiles, the property tax on automobiles. And I just don't understand how you can register your car in Virginia and then not have to pay the property tax. That's just something personally I wonder about, how they get away with that as well. And I'm happy to see there's some bills that have been submitted this year to address the issue about Virginia license plating. One thing I did want to mention is that there is a bill that the MIA did put in as a result of the task force, and it was looking at this issue of maybe setting up a low-cost auto program for those people similar to that in California. And it's also to look at perhaps subsidies to low-income people to be able to better afford auto insurance. And that was a study to try and set that framework up so that they can make recommendations for next year's session. So I think the MIA is doing a lot to follow through on some of the task force items. I've heard them testify before this committee when they were doing a briefing that they're going to be looking at territory this year to make sure that it's actually fair, and they're going to be looking at that issue as well, as long as some other insurance issues. So, but we are welcoming the idea of setting up some idea of how to address how low-income people can afford auto insurance, and I think it's important that we support that bill. It's in the House. I didn't see a cross-file, so.
And Madam Chair, with your permission, I want to address a point you made earlier about the cross-subsidization between an assigned risk plan and a carrier's voluntary book of business. I know that in some states, not to contradict my colleague here, but in some states, all of the business in an assigned risk plan is collected and priced in the plan. So if a company offers business because it's required to, it's been assigned a risk to take, those rates are not set by them individually. They are set for the number of policyholders in the plan. And I would commend your attention to the Insurance Administration who could get you specifics on that.
Thank you.
Madam Chair, that was a wonderful filibuster. But why is it, do you think that there's so many Virginia plates in Maryland because our rates are so high here in Maryland? Is that why so many people are choosing to get?
Well, I think originally, before they changed the law last year, you could go into Virginia and pay $500 and drive uninsured.
Uninsured?
Uninsured, $500. That was just saying that I have this, you make this affidavit that I can pay the bill if I get in an auto accident with you, and I'll just pay $500. That
So a
sounds
lot-
pretty,
And that's probably why they drive so erratically. I just pull over whenever I see Virginia police.
I mean, yeah, I agree.
But the last thing I'll say, and I'll turn it over, it sounds like, based off you all's testimony, you haven't had a really chance to receive or digest the amendments that.
I'm sorry, the what?
You all haven't had a chance to review or digest the amendments that Mayfield proposing.
Have
You
not
got
seen them.
Your testimony today, not that I think it'll change a whole lot, but your testimony today reflects the bill as introduced, correct?
I would agree with you. I don't think it's going to change a lot, but we're happy to look at any amendments that are offered.
Excellent, thank you. Thank you, Madam Chair.
Thank you. I just want a question about the Virginia. There's two things about Virginia. So now they have to have insurance, correct? Didn't the law change in Virginia?
Yes, they do. And one of the things is not only did they change that, but as of 1/1/2025, they raised their minimum limits for those, I mean, we're talking about people with low income. They raised their minimum limits for those that part of the population to 125, which is up there about the highest. So I don't think their rates are going to be that. And of course, if they're registering their car in some rural territory of Virginia, of course it's going to be a lot cheaper.
But no one's stopping them to see if they have insurance because they're driving in Maryland. They're not driving in Virginia.
Exactly, and that's where we're hoping that a bunch of that legislation that's circling through the Judiciary Committees gets passed.
Yeah.
Can I
no, hold a second. So you just mentioned the task force, but it's always been my understanding that a Maryland police officer can ticket you for having a registration out of state if you've lived here more than 30 days. And so, and I know they do it in apartment complexes where they see the same cars parked all the time with out-of-state tags. So it makes me wonder why this is proliferated when they had laws that could have changed it.
Madam Chair, if I could fill you in on that.
That's going to end the hearing, Bryson.
Okay.
Thank you.
Thank you, and thank you to the sponsor. We would love to see the amendments. Thank you.
I just want to say I live in Virginia and I pay my taxes.
Hearing.
She lives in Virginia, she pay her taxes.
Got to have the same rules. I let it go on too long. So next, we're going to go to Senate Bill 505. This is Senator Lamb's bill, Transportation, Aviation, Passenger Health and Safety. So Senator Lamb, you have Shannon Davis and Laura Atwood.
Have a seat. All right. Should I go ahead and get started?
Yeah, go right ahead.
All right.
Good job.
All right. Good afternoon, members of the committee. For the record, Clarence Lamb, Senator District 12, here to introduce SB 505, the Aviation Health and Safety Act of 2026. This legislation is in response to increase in federal activity at BWI Airport. And just as a baseline setting, BWI Airport is a state-owned airport owned by the state of Maryland, unlike many other large airports around the country, which are owned by a metropolitan authority or something similar. This is wholly owned by the state of Maryland. To no surprise to this audience, ICE has been conducting more deportation flights out of BWI Airport. And to give you a better idea of what these operations look like, I've compiled a short series of photos here of ICE flights from around the country. Unsurprising to all of you, detainees are often shackled in transport and on planes, which poses a significant risk to their safety in an emergency. Should a detained person have a medical issue, for example, our local EMF services would respond, but would potentially have no idea of the identity of the person in distress, much less their medical conditions or medications that they might need, but might not be provided by those detaining them. This bill addresses this issue by requiring fixed base operators to collect medical information along with a person's legal history so that these individuals at the airport and on the plane are aware of who they are and what their needs are medically. Fixed base operators are businesses or entities that have been contracted by the state of Maryland to provide airport operation needs. So things like refueling, bring up the stairs to the airplane, things like taxiing and moving planes about. Those are oftentimes handled by fixed-based operators that are contracted by BWI in the state of Maryland. This bill also requires that the state only enter into contracts with fixed-based operators who require airlines that transport detained individuals to have a valid judicial warrant, court order, or a governor's authorization for extradition. This to ensure that we hold the government responsible to legal standards when it comes to utilizing our airport. The concept is simple. If Maryland is allowing a fixed-based operator to use the state's airport to transport detained individuals, we should only be doing so with operators who are engaging in conduct with values that we believe the state should uphold. Lastly, the bill provides that a plane cannot be refueled while people are on board if those people are restrained. This is a common sense safety measure that will ensure that if there's an emergency like a fire, people who have limited range of movement will not be on board the aircraft. Instead, they must deplane prior to refueling and be provided a climate-controlled environment with access to water. The FAA does test aircraft to ensure that they can be safely deplaned within a certain period of time. I believe it's either 90 or 120 seconds. There's obviously of people that are not shackled or otherwise restrained. And so there is a real safety concern here of individuals that are otherwise restrained if there were a fire on board, particularly which is particularly high or is higher during times when the plane is actually being refueled, to not have them on board for that very reason. We've certainly taken note to BWI's opposition to the bill. We're happy to narrow the bill to certain enforcement mechanisms that they are capable of. However, in our conversations with them, which have dated back many, many months into the fall, we have not gotten clear answers that would allow us to tailor the bill. They've certainly not been forthcoming nor been very helpful for us to understand what they are capable of doing to be able to narrow the bill further if that's necessary. We obviously would still welcome feedback that respects the values at the heart of this bill. Now, I'll give an example of why this is important for folks who live in the state of Maryland. Just on Monday of this week, I was contacted by an OBGYN physician who had an individual that worked in their clinic who had a CIS number and had other documentation, who was unfortunately picked up by ICE along with her husband on Saturday, this past weekend. And they were transported to the Baltimore detention facility. And by the time the OBGYN physician had reached out to me on Monday morning, because this individual who would ordinarily report to work in the clinic was not present, and we had figured out where they had been located and such, by the time we had heard from that individual, they were on a plane about to be flown off at BWI. And that was under 48 hours that individual was arrested along Route 1, I think in Laurel, and then ended up on a plane at BWI on their way to Honduras. And so, it's instances like that that really highlight the fact that BWI as an airport is facilitating individuals being detained and also being deported without proper due process, cases that we've seen in many instances around the country. But it just shows you the rapidity at which this can happen to someone, especially if there's access to an airport like BWI where these flights are taking place. And so, within 48 hours of seeing someone picked up along the street on Route 1 and then being transported on a plane to Honduras doesn't even give enough time for the legal process to work out for due process before a judge to be able to adjudicate whether that person should be able to remain here for the timing or not. And that's because of instances where BWI is able to facilitate these flights out very, very quickly. So this bill provides essential oversight in response to these increase in flights with detained people passing through BWI Airport. We believe that these are common sense safety measures that are imperative to maintain a standard of health and well-being safety of those that are utilizing our airport, and would urge a favorable report. With that, let me turn over to the other members of the panel here, and happy to take any questions at the end.
Good afternoon, Chair Beidle, Vice Chair Hayes, and members of the committee. My name is Laura Atwood. I'm a longtime Maryland resident, and I urge a favorable report on SB 505. As an inpatient physical therapist with a clinical doctorate, I've spent my career focused on the interplay between mobility and other aspects of health. For the general public, flying has real risks due to immobility, combined with impacts of low cabin pressure and dehydration from dry air and often reduced fluid intake. I personally know 4 people who've developed clots to the lungs in the last year alone from flying. Risks of flying are intensely compounded for detained people due to their common numbers and lengths of flights, often deplorable conditions during and between flights, but especially the use throughout of 3-point shackles. These are handcuffs, ankle irons, each connected to waist chains. Sometimes there are even worse restraints, including one that's like a straitjacket called a wrap. The shackles themselves are famously painful, further reduce mobility, and can cause multiple injuries, including severe bruises, cuts, swellings, fractures, and permanent nerve damage. At BWI, as we've learned, and as I've seen, the number of flights of shackled people has risen dramatically in the last year. Sometimes people are shackled for up to 73 hours straight, 80 hours straight. We must be prepared for when, not if, people come to us in dire medical condition. Our emergency responders need information so they can act quickly and effectively. We need reasonable safety precautions that account for the fact that it's harder, slower, and much more cumbersome for shackled people to evacuate in an emergency. And they definitely should not be on board while planes are refueled. We must consider long-term ethical, legal, and financial risks in dangerously transporting people against their will, often without due process or even judicial warrant. As a medical professional, I believe my colleagues need to be equipped to respond to these emergencies in people, and as a Maryland taxpayer, I don't want to have to pay potentially considerable damages if Maryland does not take reasonable steps. I therefore urge the committee to make a favorable report on SB 505. Thank you for your time.
Hello, Honorable Chair Beidle and Vice Chair Hayes, members of the committee. My name is Shannon Davis. I'm a lifelong Maryland resident and have called Anne Arundel County home for nearly 20 years. My husband has lived here his entire life, and we are raising our son here and teaching him to care about his community. As Glen Burnie residents, we live within walking distance of BWI. We love walking on the trail. We do our best to be good neighbors to the airport, and we always hope for that to be reciprocated. However, we know that not everyone is flying the friendly skies. People on ICE deportation flights, who most likely have already had their right to due process denied, are often shackled or restrained in more extreme ways that prohibit movement entirely, regardless of how long the flight is. This is not merely uncomfortable or dehumanizing. It can be life-threatening in the event of an emergency or cause a life-threatening emergency. This bill proposes common sense measures to keep these vulnerable passengers safe. I consider these requirements the bare minimum to ensure the safety and well-being of people who cannot advocate for themselves. I care about this issue as a Marylander, as a resident of Anne Arundel County, and as a mother. I also care as someone who works with immigrants. If any of my clients or their family members were detained by ICE and hustled onto a deportation flight, it would be heartbreaking, to say the very least. It would be even worse to know that they were in chains or a full body restraint, placing them at heightened risk of death or injury. Every day, the administration refutes the human rights and dignity of migrants. Marylanders must face this moment with compassion. We owe a duty of care to all who visit our state, however briefly or for whatever reason they are here. I respectfully urge the committee to issue a favorable report on SB 505. Thank you for your time.
Thank you for your testimony. Are there any questions here? Senator Miles. Oh, okay. You forfeit your time?
Is that on me now? Is that on me? Okay. All right. Thank you, Mr. Vice Chair, and thank you, Senator, for this bill and for the witnesses here who gave testimony. I agree that this conduct is disturbing. I did want to ask, though, maybe Senator Lamb, if you could speak to a little bit. I mean, obviously, you're aware of the concerns that were raised in some of these letters, and I think you kind of touched upon a little bit, but the issue regarding preemption, could you speak a little bit about that? I know there's some concerns here about how the federal government has the exclusive authority to regulate carriers' route services operations.
Mm-hmm. Yeah, so happy to do so. There are federal regulations that require any flights in and out of an airport to be permissible to occur, right? So if a plane has an emergency, it needs to land, it can land, right? So so we are not trying to block the ability of flights to take off or land at BWI Airport. So that's where the federal requirements of preemption kind of supersede our ability to stop those types of flights, or any flights, I guess, from arriving or departing from BWI Airport. What we are focusing, therefore, is on flights that have folks that are shackled or otherwise unable to have full movement, to focus on the health and safety components of this, recognizing that those pieces are a little bit different than flights where people have full movement, especially when it comes to safety issues and being able to evacuate the flight. And then it also focuses on these fixed-based operators. So at BWI Airport, I think Signature is the FBO there. And those are operators that have contracts with the state of Maryland. And where we have an ability to be able to regulate is on those fixed-based operators, to be able to say to them that if they're servicing a plane, that they should have, and that BWI can certify that the folks on that plane are on that plane because they have a signed judicial warrant or a information that's signed by the governor or court order. And we do have the ability, which is what this bill is looking to do, to be able to regulate or narrow the ability of FBOs to be able to operate at BWI Airport, because those are contracts that they have with the state.
Okay. So you're saying then, I mean, because I see the Airline Deregulation Act that preempts state and local governments from regulating carriers' route services and operations. I think what you're saying then is that that is not applicable to fixed base operators. Is that what you're saying then?
What we're saying is that we don't believe that the ability of our ability to regulate a fixed-based operator intersects with the ability of an airline to be able to, or aircraft to operate within that airport. If somebody wants to bring in their own federal agent to refuel the plane, that doesn't have anything to do with the FBO, right? So where we have the ability to regulate the FBO, we can do so, but that doesn't mean that we should allow, that we have to allow an FBO to service a flight. They can bring in their own folks to service a flight if they choose to do so.
Okay.
Even without the FBO's support.
And then along that same lines, I know there was some concerns raised about the MAA losing access to federal funding. I mean, honestly, it's challenging because, we certainly don't want to not do the right thing just for fear of, On the other hand, it's a real concern that it looks like there's $300 million in federal funds that are in the 6-year capital plan. I don't know if you wanted to respond to that or to respond
Sure.
to those concerns?
Yeah, and that's why we've had ongoing, and Delegate Charkoudian's the one that's the House sponsor on this. Both she and I think she even just as earlier as this week, have met with BWI officials. We've met repeatedly with them to try to understand where that line is so that we don't jeopardize that federal funding, and we have not been able to get a straight answer from them.
Okay.
So we welcome a continued conversation with them. We're happy to look at narrowing this bill in any other way that would make them feel more comfortable. To be honest, I'm not sure if that line is very clear, right? Somebody can tweet the wrong way and, we're at risk of something happening. The Bay Bridge can get not constructed or something, right? So it's hard to know. Somebody could sneeze the wrong way and then all of a sudden, schools lose funding, right? Or somebody wakes up on the wrong side of the bed and transportation funding is gone. So it's hard to know where to draw the line. And to your point, then, should we not try to do the right thing just because we're concerned about, the randomness of funding being pulled and held for very unrational reasons?
Yeah, and I don't see that BWI or I know MDOT submitted a letter of information. Obviously, I don't see them on our witness list, but I suppose we'll continue to have these conversations. So thank you, Mr. Vice Chair.
Thank you. And Senator Lamb, I think Senator Giles hit the nail on the head. I was looking through the testimony that was submitted, and my issue was around preemption as well. It looked like the only one that spoke directly to the issue was the lobbyist representing America Airlines. I was wondering if you saw any legal position on there. Up until recently, I thought that we could count on the Office of the Attorney General until I got a letter of advice from the Office of Attorney General, only for the Attorney General to say that it means nothing. So I'm not sure if we could rely on that office anymore
We
for
cannot.
legal advice, since they issue letters that doesn't mean anything. So
to your point, we tried. We tried to have this conversation with the assistant AG also, and they said that they couldn't talk to us about it. And because they also represent BWI. And so, it led to a weird circular argument and discussion where it got nowhere, again, in front of BWI and their leadership there, that wasn't particularly helpful. So unfortunately, we tried to involve the Office of the Attorney General, and it was about as fruitless as you just pointed out.
yeah, so it sounds like the problem with the AG's office is a lot bigger than one would think. Senator Miles?
Family emergency.
Oh, okay. Woo. Senator Miles.
No, yeah, I just had one point of, thank you for the question. I just had one point of clarification about the application of the way it's drafted. And I was reading the detained individual, it is 5107, it's on the second page. It says the detained individual means a passenger who is traveling involuntarily or while being held in any kind of restraint. And I was just thinking, it was like, well, you've got to have a restraint on to be in an airplane. So I don't know, you can't travel without having a seatbelt on. So you're in restraint. So that would apply to virtually, that would apply, it could be interpreted to apply to everyone on every airplane.
Yeah, it depends on how you define, restrained. Obviously, we want individuals on any flights to be restrained to the aircraft so that they're not bouncing around. I think in this instance, we're talking about individuals that are restrained, to their own appendages or to themselves, right? Mm-hmm. And so, there's clarifying language needed. Happy to look at that, but I think that's the delineation that we're trying to draw between restraints.
Yeah, and then there's, and that was my one clarifying question. So I wanted to bring it to your attention. Thank you.
Thank you.
Does the bill, and I guess Senator Lamb probably answered to you, but just in hearing some of the testimony about, our neighbors, friends, community, does this bill make any accommodation for if somebody is being shackled for the purpose because they've been found to be someone who's pretty dangerous? Because based on what I'm hearing, in reading online, number one, I sat on a shackling task force for juveniles, and the word shackling sounds real bad, but sometimes it's just 2 handcuffs and something around their waist versus there are full body restraints that are much more severe. So, I mean, are you making accommodation for if these are people who've been, I mean, because we want to protect the passengers. We want the passengers to be safe on those flights as well, so the other passengers. So, I mean, is that you making accommodation for that?
So the restraints, we're agnostic to the restraints. We recognize that the restraints need to be there because these are, deportation flights. There are also instances where people might be extradited from other states to have to come back in. And we do recognize that as well because the governor can authorize an individual for extradition or, whatever the opposite of extradition is, import back into the state for specific crimes or charges. And that's fine. But I think the concern here is from a health and safety standpoint, when folks are shackled in any way, that what FAA has tested for people to evacuate aircraft is for unrestrained individuals that have full mobility of their appendages to be able to get off and fully evacuate a plane in 90 seconds or 120 seconds in the event of a fire, for example. And so, and that's why part of this bill is really focused on the having documentation of individuals, whether it's medical issues and the like, to be able to have that in the event that there is a medical emergency, that can be provided to first responders. And that's why FBOs are being asked to catalog that information as well. And so, the compiling of that information, this is to Senator Giles' question earlier, is not preempted either, right? So if there's a real concern with preemption and the fact that FBOs cannot service aircraft, which we believe that, the state has the authority to regulate these fixed-based operators, like Signature at BWI, for example, that you can still have provisions that pertain to health and safety because these are individuals that are flying through BWI, and the state, under police powers, has the ability to regulate health and safety regulations. So even if you were to take away the FBO portion of this, there can still be a requirement for individuals that are flying in shackled and otherwise restrained or restrained to themselves, not to the chair, to have information compiled for health and safety reasons. And also to not have them on board the plane when it's being refueled, because that is probably the time period that there's the highest risk for potential of a fire.
Thank you very much.
Seeing no other questions, thank you all so very much. We have on virtual a couple of witnesses. I believe first we have Kate Sugarman.
Yes, can I start?
Yes, ma'am. Please
Okay.
proceed.
Dear Honorable Chair and members of the committee, Doctors for Camp Closure Maryland chapter offers favorable testimony in support of Senate Bill 505, Transportation, Aviation, Passenger Health and Safety. Doctors for Camp Closure is a nonpartisan organization of over 2,200 physicians and healthcare professionals from all specialties who oppose inhumane detention. We advocate for humane and just treatment for all. At its core, this bill is about upholding Maryland's values of basic dignity and well-being for all people who find themselves in our state, whether voluntarily or involuntarily. This bill affirms that Maryland should stand firm in its commitment to safety, due process, and a belief in shared humanity by prohibiting dangerous and inhumane practices that also inhibit our own medical providers' ability to do their jobs of alleviating suffering. And excuse me 1 second. And then flying in shackles predisposes people to so many harms detailed in my written testimony. People on ICE flights get transferred repeatedly, sometimes up to 20 times. Flights can have circuitous routes and multiple stops. 2 people deported to Asian countries were reportedly shackled for 73 hours and 80 hours straight, respectively. Reports are common of limited food, water, and bathroom breaks with people still in shackles, which makes good toileting hygiene very difficult. It's also common for people to soil and wet themselves during these flights, which is devastating but also hazardous in terms of skin integrity, infection, and spread of infection. As a state, we have a moral and arguable unquestionably legal responsibility to reject participation in inhumane processes to the greatest degree possible and to demand that we in the medical profession have the tools to instead act as healers. For these reasons, Doctors for Camp Closure Maryland urges the committee to provide a favorable report on SB 505.
Thank you. Are there any questions of this witness? Seeing none, we will hear from Robert Cornett. Mr. Cornett, you may begin when you're ready. Right now, you're on mute, though, sir.
That'll make it hard to begin. Chair Beidel, Vice Chair Hayes, and members of the committee, thank you for the opportunity to testify. My name is Robert Cornett. I live in Frederick and work with community and faith-based partners concerned about immigration detention and deportation in Maryland. I support SB 505 and urge a favorable report with clarifying amendments. This bill addresses a narrow but urgent problem. People being moved on enforcement flights using Maryland airports often have serious medical needs or ongoing legal claims. Yet there is no clear process to identify those needs or ensure they are communicated before someone is put on a plane. SB 505 creates basic protections, medical and legal screening, and standardized forms, so that no one is placed on an enforcement flight from Maryland without reasonable steps to prevent harm. The bill is about what Maryland-regulated actors do on the ground. It does not tell the federal government whom to deport or how to operate aircraft. It sets expectations for airport contractors and medical and legal professionals, areas within Maryland's traditional authority over health, safety, and professional regulation. I do ask that the bill be clarified on 2 points. First, we would like it to be more explicit that the protections apply at any public use airport in Maryland, whether owned by the state, county, or a municipality, so they cannot be sidestepped by shifting enforcement flights elsewhere. Second, clarify that the forms are voluntary, handled by designated groundside or medical personnel, and treated as confidential information held by a designated state-regulated entity. With these clarifications, SB 505 offers a practical framework to protect people's health and safety on enforcement flights, and I respectfully ask for your favorable report. Thank you.
Thank you, sir. Are there any questions of this witness? Seeing none, that ends the testimony and hearing on Senate Bill 505. Next, we will hear from Senator Lamb on Senate Bill 416, Health Maintenance Organizations Payments to Non-Participating Providers Reimbursement Rate. Senator Lamb panel includes Daniel Stradek and Reginald Brown. Senator Lamb and panel, you should proceed whenever you are ready.
All right. Thank you, Vice Chair and members of the committee. Here to present Senate Bill 437 for the record, Clarence Lamb, Senator District 12. Senate Bill 416 aligns the law for out-of-network healthcare provider reimbursements for health maintenance organizations, or HMOs, with the law for preferred provider organizations, or PPOs, by ensuring there is a minimum floor on reimbursement rates. Out-of-network physicians in the PPO market are paid based on a benchmark rate, or benchmark date, rather, adjusted for inflation. This makes sure that out-of-network physicians are paid at a fair rate by insurers. However, the current HMO law does not use the same method to calculate out-of-network physician reimbursements. The current HMO law outlines that out-of-network healthcare providers, apart from trauma physicians, may be paid at 125% of the average reimbursement that the HMO paid for the same service in the same region to a similarly licensed provider as of January 1st of the prior calendar year. Benchmarking payments to the prior year means that healthcare provider payments may not keep pace with inflation, which is a wage cut in real terms. Additionally, using the prior year benchmark allows carriers to manipulate and artificially deflate network reimbursement rates. This bill would add a benchmark rate certain benchmark date certain of January 31st, 2019, inflated by the change in the Medicare Economic Index from 2019 to the current year. This aligns with the method used to calculate physician payments in the PPO law and is the same date established in the Federal No Surprises Act. By passing this bill, we are not changing the 125% rate in the reimbursement formula, and we are not changing the existing protections in place on balance billing for patients. We would be creating consistency and fairness by aligning the HMO law with existing PPO law in how out-of-network healthcare provider reimbursements are calculated. We have repeatedly heard about increasing ER wait times. There are a lot of factors that play into that issue. One significant factor is lack of staffing, which is impacted by reimbursement rates. You're likely going to hear from carriers that this bill is related to a negotiation between a specific set of ER physicians and Kaiser, and that we should leave this to the contract negotiation process. First, Kaiser is not the only HMO in the state, and I've heard from other emergency physicians about similar problems with other companies as well. Additionally, this bill, like the current PPO law, applies any time an HMO member has to use an out-of-network provider. For example, in our rural communities, HMO members may have to use out-of-network mental health providers, and this bill would ensure those providers are fairly paid. Finally, this bill is not saying that Kaiser and other providers can't negotiate over reimbursement rates. It is only saying that there should be a fair and reasonable floor for those negotiations, similar to in the PPO market. And with that, let me turn it over to other members of the panel. I'm happy to take any questions at the end.
Thank you, Senator Lamb. Thank you, Madam Chair Bidel and Vice Chair Hayes. I'm Dr. Reginald Brown, a practicing board-certified emergency physician. I'm a board member of the Maryland chapter of American College of Emergency Physicians and member of MedChi. I want to thank this committee for being attuned to the state of healthcare in Maryland. My emergency medicine colleagues were before you a week or two ago updating the ED Wait Times Commission. On that burning platform, slashing reimbursement post No Surprises Acts was not offered as a solution. Some of you are familiar with my testimony last year. At that time, I asked a simple question: which emergency departments in Maryland is Maryland's largest HMO in network with? I hope we'll get the answers today. Keeping it patient-centered, I think we all firmly believe that staying in network is the best for patients. The material difference in my testimony today is that we have created a coalition around emergency medicine directors that can help answer these questions. I can state confidently that Kaiser is not in network with emergency physician providers at Luminous, University of Maryland, Hopkins, or LifeBridge hospitals, and the list goes on. I have a few more questions today. How does this support network adequacy? When Kaiser providers call 911 from their urgent care centers, quite naturally selecting for higher acuity patients, who have they contracted to care for these patients at the next stop? When the emergency medicine provider continues to manage the patient awaiting a second transfer to a preferred facility, how does that benefit the patient or reduce wait times? I am in the fight to reduce wait times in emergency medicine here in Maryland. I am actively recruiting the best and brightest emergency physician providers to join our Maryland communities. My group's HMO reimbursement is nearly double in Virginia. We asked for compromise. We asked for a Virginia compromise, but our emails were not answered. The great thing is we already have a solution in Maryland. The PPO legislation is working. I urge a favorable report for Senate Bill 416.
Madam Chair, Mr. Vice Chair, my name is Dan Shattuck. I'm here today on behalf of a number of our healthcare clients, including the Maryland Society of Anesthesiologists, the Maryland Dermatologic Association, the Maryland Psychological Association, and the Physical Therapy Association. I want to just touch on a couple points. As a practical matter, this legislation the law that exists has not been updated since 2009. That was the last time there was a meaningful change in the law, which is what we have before us today. What's happening with the need for the state certain is there is no floor. The floor is ever changing year over year. What this bill is attempting to do is establish that floor, to give a baseline from which there's transparency and consistency, and that it's built off of and inflated every year. The reason the date, January 31st, 2019, is in the bill is that's a bill that emerged out of the No Surprises Act. It's a bill that all insurers are familiar with across the country. It's not picked randomly. It's picked specifically for that basis. What we want to achieve and what the clients that I represent want to see is insurance reform in a way that provides the resources that providers need to stay in the state of Maryland in practice. As Dr. Brown said, physicians want to be a network. They want to be a part of a network where their patients know they're going to get the care that they need from providers that they know and that there's no billing inconsistencies. But when those contracts are taken away from the providers in an effort to change the reimbursement rate year after year, it puts our physicians in an awkward position. Our physicians who work with their hospital partners want to be in network with all the insurers that the hospitals are in network with. But when the choice is taken away, we need a bill like this to leverage and incentivize the insurers to come with fair contracts. Thank you.
Senator Gall.
Thank you, Madam Chair. Thank you, Senator and Dan and Dr. Brown for your testimony. I remember this bill from last year. My recollection, Dr. Brown, U.S. Acute Care Solutions, that's a portfolio company of Apollo, is that right?
So I appreciate the question and the opportunity to clarify. We have a loan like any other business might have, or you or I may have a mortgage. So it is associated with Apollo, but not through their private equity. It's a hybrid investment.
Okay, but Apollo Global Management's a majority holder of U.S. Acute Care Solutions preferred equity. Is that fair to say?
I don't think that's fair to say.
Okay. How many current members of U.S. Acute Care Solutions board are employees or partners or principals of Apollo or any other private equity firm?
So our board is majority physician owners. I believe Apollo has 2 board members currently on our board.
Because, I mean, we've been having a lot of discussions recently about the role of private equity in healthcare, which I'm sure you can imagine. And Apollo, it's my understanding it owns a couple other hospital systems, right? I've got information that suggests LifePoint Health and Scion Health. Are you aware of that?
I'm not aware of that.
Okay. I just am reading how some concerns about the quality of care, some issues with quality ratings, cut services, laid off staff, regulatory investigations. So, I mean, as you can imagine, I'm just a little bit concerned whether some of that track record may also be replicated here in Maryland, but it sounds like you don't have any information about that. Is that right?
Are you referring to Apollo, or are you referring to
I'm referring to LifePoint Health and Scion Health, but it sounds like you don't know anything about that.
No, I'm not familiar with that.
Okay, all right, thank you. Thank you, Madam Chair.
Do I have any other questions for this panel? Seeing none? I think he has my witness list. Okay, I have 2 unfavorables in person, Allison Taylor from Kaiser and Matt Celentano, the League of Life and Health Insurers.
Madam Chair, members of the Senate Finance Committee, Matt Celentano here today on behalf of the League of Life and Health Insurers in opposition to Senate Bill 416. This legislation would do nothing but raise costs to consumers with 0 benefits to them. It won't improve care. It won't streamline coordination. It purely picks a winner and loser in how they are reimbursed by HMOs. The irony of this discussion is that this bill was offered by the ER docs, and the MHCC interim work group from a couple of years ago show they fare quite worse under this proposal. The whole point of an HMO product is that a consumer accepts a narrower network with the same rich benefit structure you would get in a PPO product, but comparing the 2 products makes no sense. This legislation sort of threatens that choice for consumers. The MHCC work also supports this. HMO products by design create affordability and have narrower networks. That's the whole idea of an HMO. As you all know in this committee, the No Surprises Act in Congress was passed to prevent providers from balance billing consumers for services provided in out-of-network situations. And this bill seems to want to reverse engineer that consumer protection law by indexing the reimbursement rates to 2019, which is prior to the enactment of the No Surprises Act. The No Surprises Act was a bipartisan piece of legislation that everyone supported that holds patients harmless from balance billing. This bill is an end around on that historic piece of legislation from Congress to protect unknowing patients. And the impact of this legislation will result in higher bills for consumers, increased premiums, as well as disincentivizing provider groups to join HMO networks. I would love to continue the discussion with, especially to Senator Giles' point about private equity. If we let private equity run across the healthcare system, we're only going to increase healthcare costs. And I know the chairman has a bill that's going to address private equity and consolidation from the MHC next week. But for right now, we urge an unfavorable report on Senate Bill 416. Thank you.
Nice to see you, Alice.
Good to see you. Good afternoon, Madam Chair and members of the committee. For the record, my name is Allison Taylor. I'm here on behalf of Kaiser Permanente. Kaiser Permanente provides health care and coverage to 450,000 Marylanders, including 100,000 represented by this fine committee. Our commercial plan is one of the top 2 rated in the country for health outcomes, and we do attribute a lot of that to the tightly controlled network strategy that we have, where about 95% of our healthcare services are provided by the 1,800 physicians that Kaiser employs. I would agree with the proponents that this bill is not about Kaiser in a broad sense. The same dynamics have been playing out across the country. You know, before the No Surprises Act, a lot of insurers were experiencing scenarios where companies like the proponents were increasing using balance billing as a leverage tactic to try to get higher out-of-network rate or in-network rates from insurers. The No Surprises Act specifically wanted to address that, and so since that time, as you can imagine, insurers have been, have been cutting folks out of network for that exact reason. Kaiser is just the one in this state. I think another important thing for you all to know is that this bill it would benefit certain specialties, like I think the ones who are here in support of the bill, but there's others who were not part of these No Surprises Act dynamics who have seen their rates increase over the years, and by putting this back to 2019 would disincentivize that. We would actually support something similar to the PPO statute, and I'm out of time, but someone feel free to ask me more about that.
Senator Lamb.
Thank you, Madam Chair. So just wanted to ask some baseline questions. So can you give us a sense of what percentage of emergency departments are outside of network?
Sure. So the list of hospitals that were mentioned before, a lot of those hospitals are in network. I wouldn't be surprised if a large proportion of ED physicians are out of network. However, that is not an important factor to patients, because insurers are required to give patients in network ED rates no matter what hospital they're at. I think that's an important consumer protection that the Affordable Care Act provided. The No Surprises Act addressed the issue on the other side, which was potential balance billing by physician groups. So, yeah, I mean, I think you're right that within the narrow network of Kaiser, there's fewer than other HMOs like Care First, but that's the reason.
Got it. So majority of them are outside of network. I assume, would you be open to any network negotiations on this?
Well, I'll start by saying on this bill, I do appreciate Dr. Brown and Ms. McDonough, who have had, I'd say, better discussion with me this session than in the past. And so even though we're still opposed, I want to acknowledge that. I know they have reached out to our provider contracting team about, you know, a new proposal. I have not talked with them. It's kind of outside of my lane. You know, these are two national companies, one of which would like more money from the other one. You know, I will say, you know, I'd see this bill as, it could be interpreted as just a different type of pressure tactic. You know, before the No Surprises Act, we had the balanced billing dynamic here. You know, they say they would like a national contract with Kaiser. I don't know that this bill is, you know, fostering a sense of partnership there. Just my personal 2 cents on that.
Okay. All right, but open to network negotiations, I guess, you know.
Sure.
Yeah. You know, I know there might be an openness to, you know, kind of resetting the rates at 2026. I think the concern there is that rates have dropped significantly since 2019, which is, I think, what we were trying to do in this legislation. So, you know, there's a big gap there between those rates. And so I think that's some of the concerns of the proponents of this bill, too. So.
Yeah, if I could speak to that for a second. I get where they're coming from. When, to their point about the PPO statute, that was passed in 2010, and it set the rate as 2010, so like the same current year plus an inflationary factor. We would support a similar process using 2026 being like current state plus an inflation. And I get their point about lack of some, I'd say, you know, uncertainty in the look back to the prior year. And so, you know, if that would be helpful, you know, that's something we'd be willing to work on.
Okay. All right. Thank you.
Thank you, Senator. Senator Washington.
Thank you, Madam Chair. I just want to say I like Kaiser. You guys do good work, and you guys are growing in Prince George's County and providing adequate care for so many folks in need in Prince George's, so I really appreciate that. You know, one of the things that caused me concern is that the rates are seemingly lower here in Maryland than they are in Virginia. And can you tell us why they're lower in Maryland and higher in Virginia? Yeah,
so I think, you know, Virginia's not in my portfolio, so I'm not exactly sure how we got to that state there. Kaiser is only in a couple of counties in Northern Virginia. Their main hospital partner is Virginia Hospital Center. So, you know, I don't know where the ED volume is coming there and how that has played into this. I do know that Virginia is actually looking at revising their statute and actually bringing it down to a level that's about 20% lower than what's currently in Maryland's statute. So I think if it was that type of Virginia, yeah, so that's what I'm hearing.
I mean, we're competing for staff here, right, for Virginia and Maryland, and we're trying to find the best, you know, employees to work in Maryland, but our rates are so low, and Virginia's is a little bit more comparative. I guess you would look at a nearby state to compare and contrast if you're looking at the rates in the region, because this region, and at least in the DMV, we all kind of, you know, bounce off each other for the rates that we do for whatever industry it could be. So sure. I wonder why you guys set it at such a low rate in Maryland and Virginia.
Yeah, I mean, I think I just lost my train of thought.
You can speak.
You want to answer that?
I mean, I think there's a variety of factors, Senator Washington. One is that I think we have world-class healthcare systems in Maryland that maybe Virginia might be envious of. And because of that, we have a surplus of some of the physicians that we might be talking here that actually have some of the higher rates, depending on specialty. The global budget and the total cost of care ahead model is a different factor. So it's sort of an apples and oranges comparison. We have a lot to be proud of in the state of Maryland, but we do have higher healthcare costs. And it's something that this committee and this General Assembly has made a lot of strides on affordability for the past decade or so, especially since the Affordable Care Act, but there's still ways to go.
And if I can add, I do remember I was going this. You know, Kaiser employs 1,800 physicians in the state who provide, as I said, 95% of our care to our members. And, fair compensation is something that's important to that. In addition to the bill Mr. Celentano mentioned earlier, the chair has another bill that we'll hear on Tuesday that's looking at physician costs from a more global perspective, which I think is an important conversation as we think about all these things.
Okay.
Thank you. I just want to share with the committee that many of you don't know, Allison was our Patrick before Patrick and before Amber, so it's nice to have her back. Thank you, Allison.
Great to be here. Thank you.
Senator Washington, did you have another question or?
Nope, it's just still
Okay, you want to turn, there you go. Thank you. All right, thank you. That ends the hearing on this bill, and we're going to go to the very last bill, Senate Bill 417, Senator Lamb, labor and employment mandatory meetings on religious or political matters. And you're going to bring up Nicole Jones, Kayla Mock, and Donna Edwards.
All right. Good afternoon, Madam Chair, members of the Senate Finance Committee. I'm Clarence Lamb, for the record, Senator District 12, presenting SB 417, the Maryland Worker Freedom Act. This is a bill that's not unfamiliar to members of this committee because it was brought forward last year as well. The concept is very simple. It prohibits employers from disciplining an employee who declines to attend a meeting where the employer is discussing their politics, religion, or stance on unionization. It does not restrict employers from having these meetings. They're still free to hold what are commonly referred to as captive audience meetings. What they are not able to do under the bill is punish employees who choose to continue to work rather than attend these meetings. Would like to emphasize that employer speech rights are not being infringed on this bill. They're not being infringed. Instead, employees' interests as unwilling listeners are protected. Given the disparity in power and authority between the employer and the employee, Maryland should be protecting workers who do not wish to participate in captive audience meetings from retaliation. States also have a broad ability to regulate employer-employee relations that is not the subject of federal preemption. This bill regulates in the area of wrongful termination rather than in governing labor relations specifically. The committee has passed a similar version of this bill last year in response to those concerns that had come up in 2025. We have added exceptions for legally required information, also for voluntary meetings and information that's necessary to an employee's job, as well as certain government employees. So there have been additional exemptions included in this year's version of the bill. I've also submitted an amendment for the committee's consideration that would move enforcement from the department to a private right of action. This is being done to address legal issues raised in other states. My panelists can speak to the consequences of these meetings better than I can, so let me turn it over to them and take questions at the end.
Good afternoon, Madam Chair and members of the committee. I'm Donna Edwards. I'm president of the Maryland State and DC AFL-CIO. This bill does not regulate labor relations. It regulates coercion. And at its very core, the very simple thing is that workers should not be forced to attend meetings where the discussion and the topic is not something that they willingly want to listen to. While a person is clearly always has the right to express their views to those who wish to listen, they do not have the right to force the message upon the audience incapable of declining to receive it. And that obviously is in the relationship between an employee and an employer. The First Amendment permits protection of unwilling listeners. The bill does not change anybody's right or even take away the employer's right to have freedom of speech, talk about anything they want to talk about, but what it does is prevent them from retaliating against a worker who chooses not to be a part of that meeting. And so it does need an enforcement piece because obviously if you're holding somebody's livelihood in your hands, we definitely have to have a way of recourse. I do want to point out that in Connecticut in 2022, they did pass this law. And as of Friday, the 13th, just a few days ago, I can read it directly, is that the U.S. District Judge granted the state's motion for summary judgment, finding that the Connecticut Business and Industry Association and the U.S. Chamber of Commerce challenge to Connecticut's captive audience law lacked standing to continue the suit because the First Amendment rights to speak to its employees are not impacted by the law. So that is the conclusion of what they decided in Connecticut. I know that came up last year. Workers should not be forced to listen to their employer's religious or political views, and for that, I ask for a favorable report on Senate Bill 417.
Good afternoon, Chair Beidel and members of the committee. My name is Nicole Jones. I'm a registered nurse with the medical vendor Centurion at Western Correctional Institution. I've worked as an RN and LPN for over 10 years, and my past experience includes working at NBCI, RCI, and MCTC. I love what I do. People who are housed in our facilities deserve to be treated with respect and dignity, and they deserve quality medical care. While I am passionate about my work, it comes at no surprise that my job is incredibly stressful. The workload on my coworkers and I is incredibly demanding. Oftentimes, I'm texted by management in the early hours of the morning notifying me of changes in my caseload for the day's shift. We are understaffed, and on weekend shifts, there is one nurse for the entire compound. That means one nurse on duty for over 1,000 incarcerated individuals. Due to these working conditions, my coworkers and I decided to form our union with ASFME. As we started forming our union, it became clear that our employer was opposed to it. My employer sent out mass text messages, emails discouraging us from organizing. Additionally, during my scheduled work shift, I was pulled into a room with an outside vendor who was hired by Centurion to give me a 30-minute lecture on why I should not join the union. Again, this occurred during my work shift when I was trying to collect sick call passes, which are an important part of my job to identify potential medical needs of the people in my facility. Centurion also flew out top executives and lawyers from the company and held group meetings with all of us employees to discourage us from unionizing. My coworkers and I were scared to speak up for fear of losing our jobs, and for months we were filled with anxiety, wondering what would happen to us if our employer knew we supported our union. Despite winning our union over 4 months ago, Centurion objections before NLRB have prevented certification, and thus we have been unable to bargain, and we do not have the safety or protection of union representation. Please protect other workers in Maryland from going through what we went through with Centurion. I ask that you support Senate Bill 417. Thank you.
You're good. Good afternoon, Chair, Vice Chair, members of the committee. My name is Kayla Mock, and I am here on behalf of over 10,000 members of the United Food and Commercial Workers Union Local 400 here in Maryland. And I'm also here today on behalf of the workers who have seen impacted by mandatory captive audience meetings. My first role at Local 400 was as an organizer, and it was my job when non-union workers would call in wanting to organize to walk them through the process. And I saw the impact that captive audience meetings had on workers just trying to exercise their rights. When I would warn workers about captive audience meetings, because these meetings are used in over 90% of the union drives, they would ask me if they could refuse to go. And I would have to tell them no, that if a boss makes the meeting mandatory, which most do, then they must attend. I would stress to them that as an at-will employee, as any workers without a contract are, that if they refuse to attend a mandatory meeting, even if it had nothing to do with workplace instructions or directions, they could be disciplined or fired. I want to uplift one account of workers organizing and the mandatory captive audience meetings they faced. A group of produce truck drivers began to organize their union. When the boss found out, they hired 2 consultants to hold mandatory captive audience meetings. They decided to split the workers into 2 groups for these meetings, and they did it by race. They put all the African American drivers into one meeting and all of the Latino drivers into another. The consultants told the African American drivers that the union was only for the Latino workers who didn't speak English and didn't understand their rights. And when they went into the Latino worker meeting, they told them, well, you don't need the union. It's only for the lazy workers in the other meeting. The workers, who were very close, were furious that they had to sit through these daily meetings listening to racist rhetoric being said about their colleagues, but they had to continue to attend because these were mandatory. No worker should be forced to sit in meetings like that, and for this reason, we urge a favorable report.
Thank you. Do I have any questions? Senator Mounts.
Just a quick question about what can be discussed about proposals, political, that what can't be discussed to political matters. So public policy, so that would mean federal things as well as state things, right?
Do you want to take that? No. This is not telling you that you can't discuss anything. It's telling you that you cannot retaliate against an employee that does not want to attend that meeting where you discuss that thing.
Okay, so you can discuss, say that one more time slowly for me.
Okay.
It's almost like one of those, it's been a long day, but.
I know, it's all right, Senator. No, it is not saying that you cannot discuss anything. It is saying that you cannot retaliate against an employee that does not want to listen to that. Right. So you can't go ahead, yes.
Yeah,
Senator to senator.
Sure. So it's not intending to infringe on the ability of companies and employers to have free speech. It is governing labor relations by ensuring that employees cannot be punished for not sitting through those meetings. The employers can say anything they want. They can continue to say anything they want. They just can't punish the employees for not listening to that.
Okay. So it's not about First Amendment, it's about the punishment. And there was another part of the bill that caught my attention, and it happens all the time, but at the very end where it's talking about awards and you can get your attorney's fees, if you file a claim. And then why wouldn't the employer be able to get their attorney's fees if a claim is filed against them and they're successful?
Well, the employers oftentimes, you're talking about the employers?
Yeah.
The employers oftentimes have counsel on board to.
At a cost, just like it's a cost to bring the claim. I mean, why would if you're bringing the claim and say it's a valid claim, then you would win, but you would also get your attorney's fees. But if a claim was brought against the employer and it wasn't a valid claim, the employer had to pay for the attorney. Why wouldn't it, if we're going to allow the attorney's fees for the successful claimant, why wouldn't you allow attorney's fees for the successful defendant?
I mean, I think the inability of a worker to be able to pay for counsel should not be the factor why a complaint should not be brought forward. And so I think, oftentimes the employer has much deeper pockets than an employee who may be experiencing these types of captive audience meetings and have concerns. And so I think, not having the ability for employees to be able to bring this forward, potentially have counsel supported in that way, is a way of intimidating or restricting the ability of a worker to bring these concerns forward.
And does this only apply to unions? It applies to all workplace settings, right?
It's all subjects, under that. It just means I don't have to listen to it if I choose not to, or a whole group doesn't have to listen to it.
Okay, thank you.
Yeah, thank you.
Senator, I have two questions for you. How is this bill different than last year's Senate Bill 576? Is it the same?
So there are some exemptions that are included in this year's version that were not last year. So there are exemptions for legally required information, for voluntary meetings, for information necessary to an employee's job, and for also certain government employees. So we're trying to address some of the issues that were brought up last year and wrote those exemptions into place.
And you saw the fiscal note, right? There's a fiscal note of 131.6. So I'm going to ask that you deal with that with the chair of B&T.
Yeah.
Thank you. Thank you. So that ends this panel. I don't see any other questions. So let's bring up our unfavorables. Callie Locklear, Grayson Wiggins, and Philip Missamera.
Good afternoon, early evening, honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Retailers Alliance, respectfully in opposition to this bill. Labor relations in the United States are governed by the National Labor Relations Act and enforced by the National Labor Relations Board. Federal law protects an employer's right to express views, arguments, and opinions about unionization. This bill would prohibit mandatory employer meetings on union issues, speech that federal law expressly protects. This policy judgment would be contrary to the balance struck by the NLRA, which protects the right of employees to support and join a union, and the right to refrain from any and all such activities. For that reason, similar laws are already being challenged in federal court. In a recent California challenge to their law, the court granted a preliminary injunction determining that the NLRA preempts the law and it violates the First Amendment. Beyond preemption, restricting employer meetings raises serious First Amendment concerns. The government should not silence one side of a workplace debate. And this bill stemmed from the belief that union membership should be encouraged by preventing employees from getting information that might convince them to not join or support a labor union. Banning so-called captive audience meetings does not empower workers. It limits their ability to hear information and ask questions about unionization, about representation, dues, and workplace impacts. As an expert witness, we have invited Phil Missamera here, who is the former National Labor Relations Board Chair. And for the reasons I've stated, we urge an unfavorable vote. Thank you.
Chair Beidel, Vice Chair Hayes, and committee members. My name is Philip Missamera. I'm a law partner at Morgan, Lewis & Bockius, and I previously served as chairman and board member on the National Labor Relations Board. I'm also a Maryland resident, and the Maryland Retailers Alliance asked me to testify today. For three reasons, I respectfully oppose Senate Bill 417. First, the bill's mandatory meeting restrictions prevent employers from expressing an opinion about union issues. That will create multiple track state and federal litigation because these issues are heavily regulated by federal law, including the National Labor Relations Board. Second, I believe that the courts will find that the bill is preempted by the National Labor Relations Act. Third, I believe that the courts will find that SB 417 violates First Amendment free speech. I'll end by mentioning another senator, John F. Kennedy, who addressed these issues. As a senator, he emphasized the importance of union election campaigns where, quote, both parties can present their viewpoints. And during his first year in the House, President Kennedy stated that employers must have, quote, the same free speech rights as everyone else. President Kennedy was one of the nation's most passionate labor and employee advocates, but he defended everyone's right to express their opinion about labor issues. I encourage this committee to do the same thing, which warrants an unfavorable report on Senate Bill 417. And thank you, and I'd welcome any questions from any member of the committee.
Thank you. Grayson?
Thank you, Madam Chair, members of the committee. Grayson Wiggins here on behalf of the Maryland Chamber of Commerce. As my colleagues pointed out, I would echo their thoughts on the matter. I would also just put some finer points on the issue. So, as Ms. Locklear pointed out, the California injunction was granted by a judge appointed by President Joe Biden. Additionally, my understanding on the Connecticut case that was mentioned by the proponents is that was dismissed more as an issue of standing and not necessarily a question of whether federal law preempted the issue or whether or not it was a First Amendment concern or violation. I would also note the bill is broad. It's exceptionally broad. For example, on page 2, it prohibits an employer from holding a meeting and requiring employees to be at the meeting if that meeting is concerning proposals to change legislation, regulations, or public policy. Given the swift changes that are happening at the federal level on a consistent basis, I know many businesses are having meetings with their employees to discuss the potential impact that those policies would have on their business, potentially on their employees' jobs, and how they can respond best to those swift changes that are occurring. And so this bill seems to prohibit that. I don't know why. I didn't really hear a reason from the proponents, but just given the breadth of the bill as it applies far and beyond labor relations, we also have significant concerns there. Thank you, Madam Chair.
Thank you, Grayson. Do I have any questions for this panel? Senator?
Thank you, Madam Chair. Ms. Camaro?
Yes.
Great, thank you. I have to say I'm a little bit confused, and hopefully you can provide me some guidance. I'm reading, and bear with me one moment while I bring it up. I'm reading an article that's dated November 21, 24, that reads, Employment Law Update, NLRB bans captive audience. It says, in a landmark decision, the National Labor Relations Board ruled that captive audience meetings, where an employer requires workers to attend a meeting in which the employer expresses its opinion about unionization, are unlawful. And you shared with the committee just now that, if I understood correctly, that the NLRB is the guidance on this, and that it is. So can you just clarify for me what that's about?
Well, thank you so much for the question. And the reality is these issues have been regulated by the National Labor Relations Board for 90 years. Questions concerning whether an employer engages in coercion or engages in improper speech or threats, those go all the way back to 1935 when the National Labor Relations Board first started. And in my written testimony, I note that the NLRB in the 1940s, 1948, specifically ruled.
Babcock and Wilcox, yeah.
Yeah,
Okay.
Babcock and Wilcox, based on a change that Congress made to the National Labor Relations Act in 1947, which specifically protected speech in the workplace as long as it didn't contain any types of improper threats. The NLRB in 1948, in the Babcock case, specifically said that mandatory meetings where employers spoke about union issues were lawful. And then, as it turned out, in the case that you're referring to, November 2024, a divided NLRB overruled Babcock and found that mandatory meetings in which employers talk about union issues, the NLRB, in this recent opinion, indicated that it was unlawful. But one of the problems associated with having a Maryland bill that contains these similar prohibitions is even if the same conduct is either prohibited by federal law or it's protected by federal law, both ways, state action ends up being preempted by the National Labor Relations Act. So one of the problems that I have with the bill, which I believe is well-intentioned by the sponsors, but one of the problems is an employee may file a claim with the labor commissioner under this law and think that they're just talking about a single meeting. And it turns out they will literally have a federal court case. And so there are likely to be state court proceedings that deal with federal preemption and First Amendment protection. There are likely to be federal court proceedings.
And I appreciate all of that, but I think we're not quite getting to my question. My question simply was, you represented to the committee that the NLRB governs on this issue and gave the impression that the NLRB, dating back evidently to its 1948 Babcock and Wilcox case, said it was okay. But the fact of the matter is, it isn't okay under the NLRB because they have said, if I'm understanding the ruling correctly, that captive audience meetings are unlawful. So at least at this point in time, I'm not worried about what happened in the past. The current answer to the question is the NLRB has determined that these captive audience meetings are unlawful.
My answer
Is that, I mean, can you give me a yes or no on that? I'm trying to just understand the status of the issue as of this moment in time.
The answer that I could give you are two answers. One is, it's true that the National Labor Relations Board in November 2024 found that mandatory meetings in which an employer ends up discussing union issues is unlawful. But my second answer is this. I served as chairman of the National Labor Relations Board. I was on the board for about 4.5 years. I was appointed by President Obama. And I learned over and over again during my service on the NLRB that the National Labor Relations Board does not get the last word. And in fact, the case that was decided in November of 2024 is on appeal. And when I was going through my Senate confirmation hearing for the board—
Look, I appreciate all of that. We have a very limited time in which to have this conversation. I had a very specific question, and while I value and appreciate your experience and your public service, my question was simply, the NLRB has said you can't do it. And the answer evidently is that is correct. The NLRB has said it is unlawful. Now, beyond that, would I be correct that there are several states that have, in fact, passed legislation similar to this, despite your assertion that maybe the states can't participate in this arena, but the fact of the matter is the states are participating in this arena? Would that be an accurate statement on my part?
This has already come up, and I really appreciate this question because there's a California law that deals with this issue, and an injunction was issued against the California law on the basis that it violated First Amendment rights and was preempted by federal law. And last Friday, I should advise the committee, I'm one of the attorneys representing the U.S. Chamber of Commerce in the case challenging the Connecticut law. And the decision that was rendered on Friday, and my co-panelist to the right accurately stated, that the court on Friday stated that it was denying summary judgment for the Chamber of Commerce because the ruling was that the Connecticut Business and Industry Association lacked standing. And the reason it lacked standing was that a Department of Labor official in Connecticut stated that they were not going to enforce the law. But one of the things that the court also said on Friday was that the court agreed with the California statement that the similar restrictions in California violated the First Amendment. And specifically, the court in the decision that was issued on Friday stated that the California court's reasoning, again, finding a violation, was, quote, both thorough and well-reasoned. So,
and the net, though, was the captive audience law in Connecticut has survived legal challenge thus far. Is that correct?
That's correct, but the law—
Thank you. Look, I'm just asking very specific questions, and I appreciate your desire to share a particular perspective, but I'm just trying to get yes or no's to very specific questions. And in fact, states beyond just Connecticut, Maine, Minnesota, New York, and others have passed legislation in this arena. Is that accurate?
There are other states that have passed legislation that deals with these issues, similar to the rulings that have come down both ways by the National Labor Relations Board. And we expect more decisions out of the courts of appeals and other courts.
So if we were to pass this law, we would be joining a number of other states that have done so. And the bottom line is we might all be on the roller coaster waiting to see what happens, but there's nothing that would prevent us from passing the law. And if at some point it were determined that it's unconstitutional, then we would deal with it. But in the meantime, we would have the force and effect of a law that protects employees from being threatened with the loss of their employment if they refuse to not be subjected to the employer's perspective on religion, politics, or in this case, the conversation we're having, if they want, or if they do or do not want to participate in collective bargaining.
I appreciate your comment because my concern and criticism of the bill, respectfully, is that all of the employees that the bill seeks to protect or advance their interests would also be going along for that ride and be subjected to cases that would put the employees themselves in litigation in different places for years. And
We'll leave that up to each of the employees to determine how they do or do not choose to pursue this. And I thank you very much for the discussion. Thank you, Madam Chair.
Thank you.
Thank you, Madam Chair. Grayson, I just have a kind of quick question for you. You said that you felt like the language was really broad as far as like what it was exactly restricting. I'm curious, do you have any ideas as far as like narrowing it? Or are you just entirely opposed to it? But do you think that there's any way to whatsoever narrow it? Or is just you just think overall it's too broad, period, end of sentence?
That's not the only concern we have.
Yeah, I know there's other concerns as well, sure.
I think just from a general perspective, when we look.
Yeah, I don't know.
Did I press something? It's probably my fault, sorry. Yeah, so we do have additional concerns, as I previously noted, but regarding your question, the language in the bill is, I'm not sure how you could hone down this political matters definition, because based on what the proponent said, it seems that the intent is to prohibit an employer from discussing changes to public policy that could impact the business and the employees who would be attending the meeting. And I understand that, the bill doesn't say you can't hold a meeting. It doesn't prohibit an employer from holding a meeting, but what it would do effectively is prohibit the employer from requiring employees who are, going to be potentially subject to public policy changes or dealing with public policy changes. It prohibits an employer from requiring them to attend the meeting.
Right.
Which is effectively prohibiting them from having the meeting.
But as far as like the content of the conversations, like you don't think, because I think the previous panel articulated some, legitimate concerns about some of the topics that may have been discussed in some of these meetings. So I'm just curious if you think that there's any way to say like you can't make this a condition of employment to have these kind of conversations in these meetings.
Well, again, I don't know. There's no way we're going to support limiting a business's ability to talk about potential public policy changes that could impact the business.
Okay.
I think that's a fair position for us to take, in that public policy changes impact businesses, the way they operate, and the way that jobs are created and maintained. And so I think businesses should have the right to discuss that in a meeting.
Okay. Thank you, Madam Chair.
Thank you. Senator Mounts.
Thank you, Madam Chair. Just a pretty quick question for either Grayson or Kaylee. I'm not sure. Only asked to one witness, though. But what are, for what this bill is trying to address, Aren't there existing protections already in law to prevent this type of behavior?
Kelly.
Well, the senator already pointed out that the National Labor Relations Board decades ago specifically dealt with the legality of workplace meetings, whether they were mandatory or not. The board's position for at least 85 years has been you must look at the content of what's stated in order to make a determination that a meeting or the content of the speech during the meeting improperly threatened employees. And one of the important points here is the National Labor Relations Board applies the law. Congress, the U.S. Congress, the House and the Senate, writes the law. And what the U.S. Congress wrote specifically into the National Labor Relations Act is a provision, Section 8C, that specifically says it shall not be unlawful or even evidence of unlawful conduct if an employer or anyone else expresses opinions with respect to union issues, as long as the expression fails to contain any type of improper threat or promise. But there has been regulation in NLRB cases for decades and decades of exactly these issues. And part of the problem that has arisen in states that have passed these types of laws is the fact that the litigation regarding the legality or the constitutionality of the law has ended up being protracted. And it also creates a multiplicity of places where these types of disputes go. There's nothing in this area that is the equivalent of a one-stop shop, which is actually what benefits employees the most, and it benefits employers and unions the most as well.
Thank you.
Thank you, Senator.
Yeah, thank you. I just wanted to follow up on a response that Mr.
Miscamara, yeah.
had pointed out with the Connecticut case. And you had pointed out that their Department of Labor had indicated that they would not enforce this, right? And
yeah,
so
not enforce it against the Connecticut Business and Industry Association.
Correct. So as I mentioned in my testimony, we have an amendment that we are putting forward that would move the enforcement out of our Department of Labor. This addresses the chair's concern with the cost, because the cost in the fiscal note is in relation to enforcement by the Department of Labor. So the amendment would remove it from the Department of Labor. The enforcement would be private right of action. And so wouldn't that align with what Connecticut is in their Department of Labor already saying, that they're no longer enforcing that?
Well, the way I read the bill is that the bill would actually still have some enforcement duties. The complaint would be filed with the Commissioner of Labor and Industry. And then there are also provisions in the bill that there could be enforcement proceedings in the courts. But I think it's certainly true that complaints that are filed based on meetings that are alleged to violate the statute would end up at some point in the Maryland court system. And I also suspect they're likely to end up in the federal court system as well. And it's no accident that the California statute ended up ultimately being invalidated by a federal court. And the litigation regarding the Connecticut statute also has principally been in a federal court too.
Right. Yes, the Connecticut one was in federal court, and and we were looking at that Connecticut case, which is why we are now offering an amendment to the language that stayed in the original bill to remove the enforcement from the Department of Labor. That should actually address most of the fiscal note that's in here, because that was the enforcement mechanism to allow individuals then to employees to be able to have a private right of action to sue. So that should ameliorate most of that fiscal note concern there. But that aligns with what we're seeing in Connecticut, where they have indicated in their Department of Labor they're no longer enforcing it.
Yep.
So thank you.
Okay, I don't see any other questions. Thank you. We have one last witness for the day. It's Dorothy Manovich from the Women's Democratic Club in Montgomery County, and she's here virtually, I think. There she is.
Hi, can everybody see me?
We can see you and hear you. Thank you.
Great. Thank you so much. So I will make this quick. Thank you for the opportunity to submit testimony concerning an important priority for the Montgomery County Women's Democratic Club. WDC is one of Maryland's largest and most active Democratic clubs with hundreds of politically active members in the county. I myself co-chair the Advancing Democracy Committee at WDC, and we urge a favorable report of SB 417, the Maryland Worker Freedom Act. WDC supports this bill because upholding democracy means upholding free and fair elections everywhere, whether those elections are for public office or for union representation, as we are talking about today. When employers force their workers to attend anti-union meetings under penalty of discipline or discharge, they exercise undue influence. Union organizers do not have access to the same tools. They cannot compel workers to attend a pro-union meeting. When workers' wages, benefits, and workplace protections are at stake, they deserve a fair system that will allow them to make an informed choice. An informed choice means equal access to information, and that's not the status quo because information from the employer can be mandatory under Maryland law as it currently exists. We would not accept an electoral system in which information from only one political party was mandatory, and we should not accept it in the union election context. So we ask for your support for SB 417. Thank you very much.
Thank you, Dorothy. Do I have any questions for this witness? I don't see any. Thank you very much, Dorothy. That ends the hearing for Senate Bill 417, our hearing for today. Thank you.